Good morning everybody, bore da, croeso I cyfarfod bwrdd iechyd Prifysgol Cwmtaf Morgannwg. Hoffwn estyn croeso cynnes I bawb sy'n gwylio heddiw. Good morning and a very warm welcome to everybody to the Cwmtaf Morgannwg University Health Board meeting. Can I extend a very warm welcome to all who may be observing the meeting today, and obviously to all those present in the virtual room. Because of COVID-19, due to the continuing restrictions in respect of public gatherings and essential travel, we're broadcasting today's meeting of the board live, which provides the opportunity for anyone with internet channels to observe the meeting, and a link I think has been shared prior to the meeting. So I'd like to extend a very warm welcome to all those who may be doing that today. In relation to today's proceedings, just a couple of points for those observing. Can I just advise you that we may not always be looking at the screen, as indeed am I not at the moment, because we're referring to board papers. So if we look away, it's an indication of nothing more than that we're reading our papers. And we'll also, colleagues, take a break, a short break at 11 o'clock and again at 12 o'clock if we're still in session, because it's good practice, I think, just to have a little break and stand up and walk around. So board members, for you, as you will be aware, as we have on many occasions now, we've sought questions from colleagues on the consent agenda. And so there's been opportunity for anybody to ask any questions they wish to in advance, and the answers to those questions will be published as always. So that's just by way of preliminaries. So there are a couple of thanks which it's my pleasure to give before we start on the main items on the agenda. And first of all, can I extend my thanks to Steve Webster. Steve, our Director of Finance, who is attending his last board meeting, I think, prior to his retirement next month. So very, very warm thank you to Steve for everything that he's done, the huge support that he's provided over many years to the executive team and the board. And we all wish you, Steve, a very long and happy retirement. I suspect probably not an idle retirement, but we are very grateful to everything that you have done for this health board over many years. And we're also, of course, looking forward to Sally May, the new Director of Finance, who commences post as Steve leaves next month. Can I also say a very warm thank you to Nick Lyons for the huge support that Nick has given us as the Executive Medical Director to the board over the last 2 or 3 years. Nick has left the organisation to support Welsh Government with leading the work around the COVID-19 pandemic. So Nick, a very huge thank you to you too for everything that you've done for us. And similarly, a very warm welcome to Dom Herford. Not your first meeting, Dom, I know, but your first meeting in this capacity. Dom has taken on the role of Interim Medical Director whilst recruitment is being undertaken to fill the substantive role. A couple of other housekeeping points. Welcome to Rhys Jones from Healthcare Inspectorate Wales. Rhys is here to present the Healthcare Inspectorate Wales annual report, item 5.1 on the agenda. And I think Rhys's colleague Hugh Jones from HIW is observing the meeting as well. And a very warm welcome to Dave Thomas, who's joining us in a few minutes from Audit Wales, which to take part in the discussion on agenda item 5.2. A few apologies for absence because of annual leave. So we have Callie Hamblin here on behalf of George Galletley, Angela Jones on behalf of Kelechi Noam, Debbie Benyon on behalf of Greg Dix, and Julie Denley on behalf of Gareth Robinson. Also, a very warm welcome to Val Wilson. Val's here to present items 5.3, 5.31 in relation to maternity services. Very warm welcome, Val, to you, and I think Val is being joined by several colleagues in order that any questions can be answered fully. So Mohammed El Nashati is joining us, consultant obstetrician and gynaecologist. Kathy Greaves, head of midwifery, gynecology and sexual health, and I think also Sally Davis and Steve Sewell will both be in attendance for this item too. So that's really helpful, and we're very much looking forward to that discussion, colleagues. Thank you. And warm welcome to Anna Lewis, who is one of our consultant physicians, and relevant today, she's chair of the clinical advisory group. Anna, I think, attending her first meeting in this capacity, and she will also be presenting item 5.5 on the agenda, but taking part in our discussion. So Anna, very warm welcome to you. And finally, last but absolutely not least, very warm welcome to Kathy Moss, who always attends our meetings from the Cwmtaf Morgannwg Community Health Council. Kathy has advised that she will need to leave the meeting a little early because she has a conflicting appointment. But I believe John Beecher, chair of the Community Health Council, is observing the meeting via the live stream. So that is all by way of introductions, colleagues. Apologies for absence. I'm aware of 5, some of which I've mentioned already. Kieran Montague, Gareth Robinson, Greg Dix, Kelechi Noam, George Galettley, and also apologies from Phil White. Are there any other apologies which we need to be aware of, colleagues? No, I don't think there are. Thank you very much. So we'll move to item 1.3, declarations of interest. I think, Jim, you would like to let us know of a potential conflict of interest.
Thank you, Chair. I am a non-executive director of Llandarcy Park Limited, which is leasing MRI equipment to address elite sporting injuries in Llandarcy, covering the Neath Port Talbot College of Further Education area. I mention it in light of item 3.17 in our agenda, which is the Welsh Health Specialised Services PET service, and it's in relation to the shortages of specialist staff to operate equipment in the future. And I thought it was right that I declare that on the basis of transparency. Although I don't believe there's a direct conflict, I thought it should be there in the public domain.
Thanks very much, Jim. No, I would agree. I don't think it's a conflict of interest that requires us to take any particular action, but thank you very much for letting us know. It's always very helpful, I think, for colleagues to be aware of any potential coincidences of interest, even if not conflicts. Thank you very much. And we note the usual items, including from Fiona. Thanks very much. So we move on then to item 1.4. It is our practice to, at the start of meetings such as this, to try and ground our discussions really in some of the reality of the provision of service. And today I'm absolutely delighted that we've got a short video which the team have put together. It's from a lady who experienced some complications in her second pregnancy and desperately wanted a straightforward labour similar to that she experienced the first time round. So I won't say any more. We can hear in her own words the experience that she's gained, and I think through her eyes, an insight into some of the issues that the team are dealing with. Thanks very much.
I just want to say a really big thank you to all of the midwives out there, especially those who go above and beyond in their roles. I experienced this firsthand during my second pregnancy. My first pregnancy, I was solely midwife-led. I gave birth in a midwife-led unit. This was something I was hoping to duplicate during my second. However, due to a complication between my first and second pregnancy with the Mirena coil, it did mean that I was consultant-led, so it meant that I couldn't necessarily have the birth that I'd envisaged I'd be having the second time round. During my consultant appointments, it was very scary. I was only ever being told the worst case scenarios, and I was always being told what I should do, not necessarily being listened to what I wanted to do or how I would like my labour to go. It was only after meeting with the midwife consultant and her listening to everything I said, her explaining things from the medical side to me, that we were able to come up with a solution. She was able to attend the consultant appointment with me and remind me that whilst he was saying his preferred option, there were other options available to me. I will always be grateful for that, because she reminded me that I did have a voice, I did have a choice in all of this. And if it wasn't for her, I probably would have jumped in and done something I would have regretted, delivering my baby early when they didn't need to be. So I will always be grateful for that, and for her advocating for me and my rights there. The community midwives, I get that their role has changed and they're not as hands-on, but I can honestly say that the level of care I received from them felt very similar to the level of care I received during my first pregnancy, just obviously without so much face-to-face interaction. But I got to reconnect with a midwife I'd met during my first pregnancy, and it did feel like I was just seeing an old friend every time I met with her. So that was really comforting and really reassuring. The midwives in the antenatal clinics, again, they're trying their best during this lockdown. They understand that women are going in alone, and it can be quite scary, but they were always very, very friendly and made you feel very relaxed and reassured. My midwife who helped me deliver my baby, I will always describe her as legendary, because the first thing she asked us was, is there anything in particular you're doing? We explained we were doing hypnobirthing. She asked us what words and things we were using, and just felt like the biggest cheerleader for us, especially during that last part, the hardest part of actually getting our baby here safely. I will always forever be grateful for her sticking to the plan that we wanted to do, and it just meant that my second pregnancy, whilst during the time it was quite complicated, my labour I look back fondly on now, and I'm so grateful for everyone that I interacted with that reminded me that it was my decision and my choice to go how I wanted, and I'm so glad I did. So it's just a really big thank you to all of those midwives, and you don't get recognised enough, in my opinion.
That's super. Well, what a lovely story. And a very good prompt at the end for us there about recognition of what our staff are doing, well, every day and every night of the year. That's fantastic. And we're going to come back, obviously, to the bigger question of progress on maternity services a little later on in the agenda. So thank you very much for that. And particular thank you to the mum who very kindly agreed to share her experience in that way. So colleagues, we move on to item 2 on the agenda, which is the consent agenda. So this is something that we've introduced in the last year or so to ensure that we focus on business critical activity and discussions. So we use this consent agenda, and I'm working on the assumption, colleagues, that everybody has had a chance to read all the papers in this section, and that any questions that people wish to ask, they've had an opportunity to do so. So I'm going to propose, and I would seek your approval for this, that we take the items on the consent section of the agenda for approval or for noting as indicated on each item. But if there are any items that people wish to move to the main agenda for a substantive discussion, can I please ask you to indicate so now? Jane, you'd like to make a comment. Can I bring you in?
Thank you, Marcus. I'm assuming you're including section 3.2 in this request.
Yes, please.
There's just one point I'd like to make on the action log, which is item 3.2.1. Shall I just make it here rather than move the whole item?
Yes, Jane, if you think that's sufficient, thank you. That'd be great.
I think so. It's item 7 on the action log. The original action came up within the context of our discussion of our new strategy around population health, and it relates to our ambition for our population to have good quality employment with living wages. And as part of that discussion, we discussed the Health Board's leadership role in not just paying the living wage, but actually accrediting as a living wage employer. We felt, certainly from a board perspective in that discussion, that as an anchor organisation in the region, formal commitment might well be a good idea. We seem to have an answer, which is that because there would be a cost of £480 plus VAT attached to such accreditation, that there's no need to accredit. I'm rather disappointed with that as a view. I think formal accreditation would actually show the leadership that the board would want to have in support of its new strategy. And I suggest that it might be useful to have a policy paper with a full discussion of the pros and cons to the next People and Culture Committee, so that we could actually talk about the issue in the round.
Thank you, Jane. I think that's a really good point, actually. I remember the discussion that you've referred to, and it does come back to the Health Board's leadership role, doesn't it, in this agenda, and particularly as we're talking about becoming increasingly population health focused, because clearly poverty and all that goes with it is a huge fundamental issue there. Hal, I wonder, would you like to comment on that?
Yeah, no, I agree. I think that's a really good suggestion on Jane's part, and I'll take that forward with the team for perhaps the next committee, and we'll go from there, if that's okay, Marcus.
Super, that's really helpful, Hal. Thanks very much indeed. Colleagues, any other comments? Anything else anybody wants to raise on this consent section of the agenda? No, I don't think so. I'm afraid I'm having slight problems with my Teams at the moment. I keep losing the screen, but I'll continue if you can still hear and see me. So there we are. So we will take those items then as described for noting or for approval as indicated on each individual item. And colleagues, we'll move then on to the main agenda. Item 4.1 is matters arising not considered on the action log. Is there anything anybody wants to raise there? And because I can't see the screen, I'm afraid I'm going to have to rely, Callie, on you just telling me if anybody has raised their hand.
Nobody's raised their hand.
No, great. Oh, the screen's come back on again now. This is the wonders of Teams, isn't it? Brilliant. Okay, thank you very much. That's good. So we'll move on then. So we've got, I think, I count 12 or 13 substantive items now to go through. So there's a lot to cover, and some of these are quite complex items. So we'll move straight on. Item 5.1 is the HIW annual report for the last year that's just finished, and I'm delighted. Rhys, I can even see you on my screen. Rhys Jones is here to present the report which the board are being asked to note. Rhys, thank you very much.
Thank you, Chair. Bear with me for a second. Let me just share my screen so I can share with you the presentation that you've got in your packs. So hopefully you can see that now. So yeah, so bore da. So I'm here to present to you HIW's annual report. So this relates to activity relating to the findings of our work undertaken during the year 20 to 21. What I'll also use this as an opportunity to do is to touch upon how we've adapted as HIW within the last 18-month period, give you a sense of what we've found nationally from our work, and then focusing more intently on Cwmtaf Morgannwg and what we've found within our own work within the Health Board over the last year. And just to, I guess, re-emphasise that as per usual with these reports, this is a summation of the activity that's been through all the clearance processes and has been published on our HIW website. So that's what the basis of this is. So I've got a very general slide here just to give you some sense of a background around our role, purpose and goals. I hope you're all familiar with this, but that's there for you as a point of reference. And I guess as with the Health Board, it's been a challenging year for HIW as well. Initially, all our on-site activity was suspended back in March 2020, and that caused us then to sort of reconsider redesigning our approach to allow us to still discharge our core purpose, something that clearly remained important throughout the pandemic. And part of our role in maintaining oversight meant that we had worked closely with partners. Intelligence possibly gained a heightened sense of importance in the challenging times in the absence of maybe an on-site presence. So, for instance, our concerns and statutory notifications functions remained operational throughout, and we continued to escalate issues of concern as and when they arose to us to organisations for assurance as and when necessary. So that absolutely continued. What we did then was also then introduced our new adapted approach to inspections that we were calling the quality checks. So these relate to an off-site activity assurance process, and focusing on 3 key areas: infection prevention and control, focusing on governance, specifically around staffing and around environment of care. And what we specifically sought to was to explain that the arrangements that had been put in place by organisations to protect staff and patients from COVID-19. And it also enabled us, through virtue of this being a sort of a more abridged reporting process, to provide faster and more responsive feedback on what we found during this time. So in terms of our overall All Wales activities, here is the summary of our activities during 2021. We still undertook 18 on-site inspections across the country, and these predominantly rated to areas that were of sufficient concern or risk that required us to have an on-site presence. And I think it's probably most of that work was in the independent sector. And I've also mentioned our concerns team. So again, the numbers here do demonstrate that I suppose that there remained to be an extremely busy year, and people were raising concerns with us, and it was another mechanism where we were able to seek assurances from organisations and also use that intelligence to dictate our work. So I think the majority of certainly the on-site work, the genesis of that work would have been through information that came to our attention through our concerns on notifications process. So that flow of intelligence and information continued throughout. And then on this one, again, a further breakdown of our activity in the year so that you can see how the numbers were spread across the various pieces of work. So in terms of our All Wales theme, so back at the end of June, sorry, we published a national review relating to COVID-19. So again, this was a summary across all sectors in the NHS and independent sector of the key themes and messages that had arose from our work during the previous year. And overall, the key themes were that overall the standard of care delivered was good during the period of unprecedented challenge. We noted rapid response from services, adapting their environments and introducing new ways of delivering their roles. We could see that there had been innovative approaches implemented to support patients' physical and mental well-being, wide range of changes made to infection prevention and control, and clearly staff at all levels demonstrated a tireless commitment and worked flexibly throughout the challenges that they encountered. So they were the very, very high level themes that we reported on at the end of June. So focusing then a bit more intently then on Cwmtaf Morgannwg. Here's the breakdown of the work we undertook in 2021. So you can see that we undertook a dental quality check, hospital quality checks, mental health quality checks. There was also an on-site dental inspection, and we'd done a programme of work on looking at the mass vaccination centres, and we visited 2 of those centres in the Cwmtaf Morgannwg area. In addition to the work I noted on the previous slide, of course, we undertook the joint review follow-up with Audit Wales, following up on the November 9, 2019 review. The board will be familiar with those findings, but briefly, the broad messages from that review were that the Health Board has made good progress in relation to the 29 recommendations set in the context of the challenges of the pandemic, of course. It's clear, I guess, that you know, compared to previously, the accountability and responsibility for quality and safety is much clearer than ever before, and arrangements of identification and management of risk have been strengthened, with positive steps also taken to improve organisation culture and learning, and where we'll get to the Health Board's response to the updated response to the recommendations in a following item. And then in relation to, I guess, our own work within the last year that I've noted on the previous slide. So again, broadly, our own programme of work was broadly positive. Evidence again that the Health Board has adapted and responded accordingly to the challenges of the pandemic, which have been significant. One area of improvement we consistently identified, and this was an all Wales issue as well as within Cyntaf Morgannwg, but compliance with mandatory training, absolutely there's been challenges in being able to deliver that. But we would also, as the inspectorate, always make it clear that mandatory training is an important element of making sure the staff are equipped to deliver safe and effective care. Our own engagement with the Health Board, as I've touched upon earlier, in terms of our role in seeking assurances in response to concerns being raised with us, our own engagement with the Health Board has been very positive. So we've had timely and substantive responses when we've requested them that has provided us with that level of assurance. There's not been a to and fro process. We've generally had the assurance we wanted at the first attempt or at the first ask, which is positive. I'm breaking it down slightly further now then. So in terms of our hospital quality checks, as you can see in the slide, you can see where these were relating to which services. And in terms of the positive findings, again, processes in place to ensure staff were up to date with guidance regarding COVID-19 arrangements, increased cleaning schedules, evidence, and good audits, infection control audits in place, and good support from the IPC team. And again, you know, from the mass vaccination centres, we're overwhelmingly positive feedback from those people using those services or accessing the vaccinations through those services. In terms of some of the areas then to focus improvements on, as I touched on, compliance with mandatory training it requires some attention. Sometimes it needs to strengthen actions as a consequence of doing the audits. The audits is going halfway, I suppose, identifying the issues, then the action on the back of those needs to be followed through. And there was one immediate assurance issue letter issued in relation to one of the max vaccination centres relating to resus equipment and fire risk assessments. So in terms of my next slide, these relate to the quality checks we undertook in relation to mental health services. So again, positive findings were that services again adapted to meet the needs of and the challenges of the pandemic, staff working incredibly flexibly to ensure the needs of services were met. And things like we noting the use of video calls, electronic equipment to maintain that important contact between family and friends during this time. In terms of improvements, there was an issue around ligature risk assessments. So again, the ligature risk assessments, they were being done, but then there was needed to be more evidence of timely actions as a result of those. Separately from this, we've also escalated this as a bit of a national issue with Andrew Goodall, because it's something that's come through other areas of work as well. But nonetheless, it was something we identified in on some of the Cyntaf Morgannwg work. And then also then again, elements of mandatory training were like mandatory training compliance requiring attention. And I suppose a risk inherent with redeploying workforce and I suppose the increased potential for unfamiliarity of staff working with maybe a complex or high needs patient group. And then last but not least, in terms of our dental work, as I touched upon, there was a quality check and an on-site visit that was in response to some concerns that had been raised with us. So in terms of the positive, again, in terms of the on-site inspection, there was positive interaction with the Health Board. It was an NHS and private practice, and there was immediate steps taken by the provider to address the issues. And then following a revisit, we were satisfied with the actions that had been taken. But I guess that the negatives, I suppose, is that the consequence of the concerns was that there was enforcement action taken as a consequence of the visit, restricting the ability to see patients in a dental practice, and there were some significant concerns that we identified in relation to decontamination room and infection and prevention control. As I've said, these have now been resolved, and we have been satisfied following the revisit. So I hope that the board has found that to be helpful as a summary and synopsis of what we've found over the last year. As I said, the findings that I've taken you through will be included within HRW's overall annual report, which will be published in September. So there will be a subsection within that relating to Cwmtaf Morgannwg, essentially recounting what I've taken you through there in terms of the key findings. So diolch yn fawr, and thank you very much for the opportunity this morning.
Diolch yn fawr, Rhys. Thank you very much. That's really helpful. Certainly from a board's perspective, the feedback from HIW is one of those critical elements of triangulation of evidence that we rely so heavily on. So that we're really grateful for that. In fact, almost most grateful when you find cause for concern, because that helps us in our tasks. And I am just still almost astounded, really, at that overall comment that the quality of care in the health service in Wales is good. When you consider the pressures over this last year, when you think back to, when was it, February, March of last year, and you saw what was happening in Italy, and then subsequently in some cities in the US, those were health services that were buckling under the pressure. And it's a phenomenal tribute to our staff, I think, that we managed to maintain overall good care. I think is really a huge tribute to them. So I've got a number of colleagues who want to come in. Jane, first of all, to you. Thank you.
Thank you, and thank you, Rhys. As chair of the Quality and Safety Committee at CTM, I wanted to say a particular thank you for the work of Health Inspectorate Wales over this difficult and challenging year. We really valued the insights and indeed the triangulation that your work brings to us in our scrutiny and seeking of assurance about our services. It does make a real difference. We obviously are paying attention to what you've been saying to us, and the issue of ligatures and ligature risk assessments is firmly on our agenda, I would assure you, and we will be discussing it at next week's meeting, or week after. And I also wanted to comment on the low levels of uptake of mandatory training. It's, as you are well aware, has been a long-term issue for us, and it got worse in the last year for understandable reasons. But both in Quality and Safety and in People and Culture Committee, we are pressing to resolve this as an issue. Have we set the right mandatory training for the roles? Are we sure of its relevance? And are we giving staff the time and ability to complete it? But a big thank you from us.
Thanks, Jane. That's very helpful. And Ian, you're next.
Yeah, thanks, Mark. As Jane actually said what I just wanted to comment on, which was the compliance on mandatory training part of things. And I was going to come on about the fact that this is an underlying issue that we need to address. It's not just a COVID issue. So I won't say any more because Jane's already said it. Thanks.
Thanks. But that very helpful emphasis, really, the seriousness we take this. And Hal, thank you. You're offering to give us a quick update on that, which will be very timely. Thank you.
Thank you, Marcus. Just very briefly on that. So we now have a sort of remediation plan from each of the 3 ILGs on stat and man training. So there are some system issues that Jane alluded to there in terms of what exactly it is that we provide and how we do that, which we're looking at. But we do now have a very good plan from each of the 3 ILGs, which is now being monitored via the performance arrangements within the Health Board and then via People and Culture Committee then as well. So we're in the early stages of that plan. We're kind of a month or 2 into it, but we are now monitoring that on a live basis, and expectation is clear there.
Hal, can I just be a pain for the benefit of people who maybe aren't familiar with some of our abbreviations? ILG.
Oh, forgive me, Marcus. Sorry. So that's our integrated locality group. So one in Bridgend, one in Rhondda, Taffili, and Merthyr and Cynon. Super.
Thank you. Colleagues, any other comments that anybody wants to make on this? Patsy, you've got your hand up.
Yeah, sorry, I'm having trouble with Teams. I can't put notes in because every time I do, it throws me out of Teams. So apologies, it's going to have to be visual. Yeah, the report was really interesting. I've just got a couple of questions, Rhys, if I may, largely relating to page 11 of the 14. There's a comment on the need to strengthen actions as a consequence of audits. So I'd just like a little bit more detail of that, particularly given that you'd praised the health board for the progress it was making. So it's which audits and how you see that improvement. And a quick update really on the improvement letter that was sent or that was needed regarding resuscitation equipment and fire safety risks. Have those things been resolved? I know you said the decontamination room issue had been resolved. That was my other question. Don't need to ask that. But the resuscitation equipment and the fire safety risks, again, are important. Thanks.
Yes, absolutely. So yeah, I should have added actually. Yeah, I apologise for that omission. Yeah, so that was resolved. So that media assurance process, what we did was we would have raised it to the health board, and we had a response back immediate within the allotted time frame, and we provided with that assurance that those issues have been addressed. So absolutely, those were addressed as quickly as we were raised. And then in terms of, I guess, the need in terms of audits, I haven't got to hand exactly precisely which ones they were, unfortunately, but I think the sense was good that the audits that had been undertaken, good that things had been identified. We just needed more assurance that then things were being followed through to completion or mitigation at the very least. So I think that was the general principle with those ones. I can circulate with you with more detail if you'd like in terms of which specific reports they related to, but they would have been in relation to the 3 quality checks over the hospital site. So it would have been in at least 1 or 2 of those ones if you want to have a look yourself. But I think it was the principle of great audits undertaken, identifying the issue, following them up and following them through then needed a bit of strengthening. It was a general thing.
Sorry, thanks, Rhys. That's great. Patsy, does that answer your points?
Yes. Yes, it does.
Super. Thanks. Nicola, we come to you next.
Thank you, Chair. Rhys, my question is on your presentation, but I'm not quite sure whether you can answer it or whether one of CTM execs need to answer it. And it's on page 12, and it's regarding the workforce and redeployment. You know, we're still in really uncertain times, aren't we, as to whether staff will need to be redeployed. And these patients are particularly vulnerable and need consistency. So I'm just wondering, because I can't see in our follow-up management any plans as to how we would mitigate not redeploying any of our staff from these areas and using bank and agency in the areas we would have redeployed them to.
I guess I think it is probably more of a question for the health board actually. That says Nicola. I guess I think we've recognised it as a risk inherent with there's continuity of care for that vulnerable group is absolutely important, and I think it was identifying the fact that clearly there's needed to be flexibility within the workforce, but that there is some net risk, I suppose, as a consequence of that. As I suppose in terms of the health board, then it's about managing and mitigation of that moving forward, if that remains a possibility or a likelihood.
Thanks, Rhys. Let's have some response in on that. Hal, you're offering to come in. Thank you.
Thanks. Dom Herford and Debbie Benny may also wish to come in here. I mean, this is very tricky, isn't it? So when we're in a situation where we're potentially having to redeploy staff because of the circumstances we found ourselves in previously, then that is a significant issue. I guess there's a couple of things for me which would mitigate that, which were actions we took last time around, and we would look to develop those further this time around if we need to. And they are around making sure we've got appropriate mentorship and arrangements in place for people who are working in areas that are unfamiliar to them. And I think we learned quite quickly in the last 2 waves where we were on that and strengthened our arrangements. And secondly, there's also something then around training, so ensuring that any staff who move between different areas are appropriately trained. And then there's also something for me around familiarisation and induction. So we've got clear procedures in place, particularly for bank and agency staff, where there is an induction process that takes place to familiarise. But again, I would expect that to be also in place for staff who may be redeployed, as well as then regular check-in with their home area, so that people have the well-being support that they need, because we obviously know that from the first 2 waves that it can be very stressful as well for our people when they are asked to work in an area that they're unfamiliar with. So those are the things that I would probably mention, Marcus, and I know Dom also has a comment.
Great, thanks, Hal. Julie, anything you wanted to add on that? Julie Denley.
Thank you, Chair. Yeah, just to say, I think there's a spectrum of staff, isn't there, Nicola? Some who will have really enjoyed that experience, and Howell's described very well all the support mechanisms around there. Some who will have enjoyed that experience less, I think, working in at more unfamiliar areas. So it's important we feed that into our thinking, because we may well find ourselves in similar positions again, won't we? Over the coming winter around this now, and having undertaken some service visits recently, as some of the restrictions have lifted. I've encountered staff in some really obscure places who were redeployed to, equally obscure places in the context of their previous jobs in the course of this, who really valued the experience after the event, but recognising that support as they start that journey into a different clinical area is critical to how they experience it.
Thanks, Julie. And Dom, from a medical perspective?
Yeah, Julie managed to get in with one of the comments I was going to make, which is entirely that, is that we've got a lot of problem with it. Some people are very keen to actually do those, and maybe they're the ones we need to target if ever we needed to in the future redeploy again. But I think that the main message would be we would only deploy unless we absolutely had to. And I know we did last time, but we really need to be careful this time. We need to maintain our elective work as much as we possibly can now that we've restarted it. And our concern, though, is that at the same time, this is in a background of not so much COVID, but other respiratory illnesses building. RSV is the main one that we're worrying about now. All the other viruses that no one's been exposed to for the last 2 years, including our 1 to 2 year old children. We are going to get a bigger impact from that over the next few months. We're seeing it already, and we believe that's just going to build over the next few months. So as Reece sort of commented on earlier on, it's redeploying if we need to, but having a strategy in place before we get to that stage of having that support in place, having that training need when we know it's going to happen. We almost push the button on training sooner than we push the actual redeployment. But it's just something we're going to manage. We have experience of it, and we see the impact on our staff, and we need to limit it as much as we can. But it's awareness, and there's no perfect answer for that. But we will do our utmost to prevent that impact upon our staff, and also maintain our high standards for all our patients.
Thanks, Tom. Nicola, coming back to you, does that cover what you would hope it would have done?
No, and perhaps I wasn't quite clear, Marcus, because I think, we all know staff have been redeployed and lots have enjoyed the experience. I think for me, the point on that statement there was the unfamiliarity for patients. So patients were seeing, use of agency and bank staff. So it was unfamiliar for the patients. So my question was around, if we are redeploying staff out of mental health services and bringing bank and agency, why aren't we utilising those bank and agency staff elsewhere? So the familiar staff to these patients in these areas stay in those areas?
Good question. Good question. Who wants to come back on that?
I will. There was an element, unfortunately, of not the only reason, but some of the elements to that is that it was very difficult to recruit agency staff to go to work in those sort of COVID-rich areas. It was much. The ability was there to recruit to the non-COVID front line than it was to actually recruit to the other services, and that's how that ended up getting into that position. So we had to use our own staff for that, just to be able to cover the gaps that were needed. I take your points completely, Nicola, that the patient care and the effects on the patients and who they saw on that, it was at the time that the best we could possibly do. And I think it's something that hopefully we wouldn't do again, but if it's not so much COVID and it's more the other respiratory viral illnesses, we're probably more likely to be able to recruit into those frontline posts this time round, because there isn't that scare or the worry about the COVID and the vaccine for that, and the vaccine obviously will help with that. So that's not a perfect answer for you. I know it's an awareness of the problem, really. I think that we need to think about how we plan next time.
Thanks, Dom. Nicola, final word on that.
Yeah, thank you, Dom. And there is no perfect answer. I think for me, it's just about being aware in the future that we can try and maintain as much as possible those familiar staff for those patients. Thank you, Chair.
Right. And Harold's suggesting that it's maybe something we can pick up separately and consider in future plans if any similar situation is to. Thank you. Okay, colleagues, I'm going to move us on then. Thank you, Rhys, for that presentation. That's really helpful, because this then sort of is a natural segue, I think, into item 5.2, isn't it? Which is the joint HIW Audit Wales review of quality governance, the summary of progress made up until well, a couple of months ago, I think, wasn't it? Callie, I think you're going to present the management response to that. Over to you. Thank you.
Thank you, Chair. Just to say, following the last board meeting in May, where colleagues received the follow-up review of findings, colleagues within the Health Board have been refining our management action plan. And I'd like to extend thanks to Rhys Jones and Sarah Etley, who've considered our action plan to make sure we've sort of met the expectations within that. So we have been refining that, and we have been taking on board those. We've made sure we've got targeted actions with clear deadlines to make sure we're addressing those findings. And so the action plan will now be monitored as part of the audit tracker via the Audit and Risk Committee. So we're asking the board today to approve the action plan. But firstly, if I may, Chair, I'd like to bring in Dave Thomas from Audit Wales in case he'd like to add anything since the activity from the last meeting, but I wasn't going to pull on more than that. Thank you.
Thanks, Callie. Dave, warm welcome to you. Over to you. Thank you.
Thank you. Good morning, all, and thanks, Callie. Not much to say to add to that, just to endorse from our side the thanks from the joint review team to the way the Health Board's engaged. This is always a good idea, I think, just to run a draft version of the action plan by the team that's made the recommendations to ensure that, you know, you hit in the right spot. And we felt with a bit of comment back that you've got there, so that's a positive approach. It's a comprehensive action plan. Challenging in terms of some of the timescales, but that's good because you want to maintain pace. Positive to hear that you've got the governance in place in terms of the internal tracking recommendations, because last item, and of course the context of COVID and the uncertainty of the winter, you know, the pressure on resources is going to be there as well. So we accept that. I think the one point I'd probably make more generally is to, other than keeping an eye on how realistic the timescales are with other pressures, it's, I think, with action plans like this and recommendations in them, sometimes they can be quite task focused, you know, so we produce a strategy, tick, done it. It's actually keeping your eye on the outcome prize, really. You know, if you're doing something, what is the end game you're trying to achieve? So always keep in sight of, you know, the actual outcome beyond the actual task, if that makes sense, Callie and Marcus. I hope it does, but it's something which, you know, is easy to trip into. You know, we've done that next action. It's about actually the totality of what you're trying to achieve in terms of the quality improvement here. But in short, in summary, it's a positive response. We'll keep our routine engagement going with it with George and Callie and colleagues, and we'll advise probably a little way down the line as to whether we think any further follow-up is needed. I mean, accepting that there's still action to be done in all the original recommendations, it probably feels like there's one more pass needed in terms of follow-up work, but we'll do some initial tracking with the Health Board first, so just gauge progress as a first step in that. And I'll just leave it there, Marcus, but happy to take any questions with Rhys on that wider approach.
Dave, thanks very much. That's very helpful and a very, very timely reminder that, you know, the point of all this is to make a difference in the real world, not to have nice looking reports, isn't it? And maybe just on that, can I ask Dave, Rhys, in terms of how COVID has inhibited you in doing the sort of checking that you would normally do? I presume that is the case. It must inevitably have been so. Is there a caveat for us that comes out of that, or not? Thank you.
Yeah, thanks, Marcus. That's a really good question. I'll kick off and we can chip in as well. There is a caveat. A lot of the colour we got from the original joint review back in 2019 was the drop-in centres we did in clinical areas, was that face-to-face, contact with staff. We managed to do some survey response, but it wasn't, the volume and the colour that we had from the original review. So we felt we had enough, more than enough, to be able to say what we said as part of the follow-up, a well-triangulated evidence base. But it's an important point to put on the record, Marcus, that our inability to be in those clinical areas talking to staff in normal terms did mean that we perhaps couldn't actually say, well, is it different for you, how does it feel, so we've got a little bit of that, but we didn't have as much as in the original review, and that's partly why we're thinking maybe there's a final pass in terms of follow-up where, fingers crossed, we can get back on site safely. Might be helpful.
Thanks, Dave. Rhys, did you want to add anything on that?
No, nothing in above that. Yeah, I endorse exactly what Dave said, because I think it was in a sense a qualified yes, and I don't mean that in a negative way. It because we didn't go as deep as we could have if things were normal, I guess. So yeah.
I should say as well, just for sort of balance, follow-up work is by nature slightly more high level, so if we repeated the whole joint review 3-4 times, you'd probably be sick of the sight of us, really. So we have to get the balance of getting the evidence base to be able to give you assurance that and the wider public that progress has been made with, managing the sort of, the impact on the service in a particularly challenging time, and giving the people who had taken the actions the space to take them.
Super, thank you. And Callie, just on that point, well, on the point of getting out there and seeing what's going on, as it were, we're quite advanced now, I think, aren't we, in reinstating, for example, independent member walkabouts, attaching that to board meetings, etc., etc., etc. So all of that is almost ready, almost complete.
Yeah, it's definitely in train. It's something that George and I will be picking up when she's back from leave, to see when we can start that, based on obviously an assessment of where we are in the current situation. So yes, thank you, Marcus.
Thank you. Colleagues, anything else anybody wants to raise in relation to item 5.2? I'm just looking at the chat bar, and also I'm conscious, Patsy, that you can't use the chat bar. So if you appear, I will bring you in. But it looks like that's covered. The
Marcus, can I just come in? Sorry, yeah. I was just reflecting on that point about getting triangulation with sort of hearing from staff, and I'm just conscious we have Anna Lewis on the call, who's the chair of our clinical advisory group, and it may be there's something we could think about potentially. That's a very much a cross section of frontline staff who are, from across services and across the ILG areas. And I'm just wondering, also moving forward, we might want to talk to Dave and Rhys about, whilst we want obviously to get you out into physical services, there is also other routes to get some frontline perspectives from a group of people there in Anna's advisory group, who may be a good sort of triangulation point for you as well, to sort of test some of this out.
Excellent, Paul. Thank you. That's really helpful. I can see nods all around. That's really good. Good. And Anna is saying yes, definitely. Fantastic. Thank you both very much then for that item 5.2, and we will continue to watch this closely because it's obviously so important. Thank you very much indeed. Let's move on then to item 5.3. And again, not at all unconnected to the discussion we've just been having, but item 5.3 is the Neonatal and Maternity Improvement Programme. And I think, Val, you're going to kick off on in talking about this. Thank you.
Thank you, Chair. Yes, as you're aware, we've recently welcomed Steve Sewell as a Programme Director, and Steve is with us this morning to talk us through the new style of reporting and new methods of working in the programme.
I hope you can see and hear me. A nod would be good. I've had technology problems getting in, but I'm eventually in, and I'm on an iPad, so if it's not that great a quality, I really apologise. So you have a programme highlight report from the programme. It's the first time in this style that the board has received this. we've been using this with other groups over the last few weeks. It's a shortened version of the progress report. It focuses on the key successes, but also the key challenges, and is in a format which is stolen in terms of style from the Health Board PMO. For this meeting, we're asking you to note the report, because at the moment there aren't any key decisions. We're not seeking support from the board, and there are not any real key discussions that I think we need to have with the board. The highlight report is produced monthly, so this is the June report, so there are things that have happened since then. And the July report will be available in early August. So I'll quickly take you through the report, and then I'll take you through 2 or 3 key points in terms of what's happened since this report was generated. So I'm going to call page 1 the first page of the colourful stuff, if you like, that's in the highlight report. And there is really a fairly typical programme overview, key milestones, some of the key metrics, some of the risk registers drawn from the risk register for the programme, and some key messages at the top. In the second page of the report, we've got IMSOP next step actions. There were 10 IMSOP next step actions from the report from IMSOP to the Health Minister almost a year ago, and so these track those specifically. And then finally on page 3, from each of the work streams across the programme, there are the key kind of pithy messages from each of those, some of which relate to the previous 2 pages. So in terms of what's happened since this report was produced, pretty major event in that IMSOP visit took place, and that took place last week. It was a combination of virtual and on-site. It was on the whole really positive. The feedback, the verbal feedback, we've not had any formal written feedback from IMSOP panel yet, but the verbal feedback was very positive. There were still some issues and some challenges identified, which is what you'd expect at this point. The second thing to note is that with delivery unit involvement in SIs, the way that we report on the top of the 3 pages, the SI progress, we'll start to move away from SI backlog towards SIs as a total, because that's how the piece of work with DU and how we're moving forward with SIs. The third thing to note is that the SROs at the top of the page, Dom is down as the SRO for neonates there, but actually over the last month we've appointed Sally Davis, the incoming Deputy Director, as SRO for the neonatal aspect of the work. And the other big news really in the last month is that we took control as a health board of reviewing the evidence before it goes through to IMSOP for them to verify, and so we as a health board are the primary assurers, and in a very rapid time we were able to take 4 recommendations through that process, and they are now with IMSOP for verification. I'm going to stop there and invite questions.
Great, thanks, Steve. I'm sure a number of colleagues will want to come in. Can I just ask a general question? I'm looking at page, I think you called it page 3. It's the last of the landscape ones, and a couple of questions really. One is I'm not getting from this a sense of where we are with these key risks really. So you've listed a number of really quite frightening sounding things there. I could do with some indicator really as to whether those risks are being managed and to what extent. or whether they are live risks which we haven't got to grips with yet. Just some sort of sense of where they are at the moment. And then I had a specific question about the quality of women's experience little box. I'm afraid I didn't really understand it. So an explanation about that little box would be very helpful. So those two questions to start with, Steve, and then we'll go around the table. Thank you.
Okay, so on risks, some of the risks, as I look at the page there, some of the risks have been mitigated already. I think if there were risks we were worried about and that were out of control, we'd definitely be bringing that to board. There is a risk register and a risk and issue register, and we monitor and we update that roughly every 2 weeks, just to make sure that we're managing those risks as best we can. So, for instance, the COVID risk is number one, some of which we need to tolerate, but there are other aspects of that we can provide mitigating actions against. And actually the IMSOC visit is a reflection of having managed to mitigate some of those to allow that to go ahead. So perhaps it's helpful to have a little bit more in depth in the report around some of the key risks. I don't want to go around them individually, or we could be here a little while. On the quality of women's experience, Val may want to come in a moment, but the two key messages there are: there's a PREM system which the health board is, so it's called Civica, and the aspect that we're looking at are the experience measures and a series of surveys associated with that. And at the moment, we're still going through the testing phase for those services before we then roll them out. And that's a key milestone actually within that piece of work. So I understand actually how that is written. It doesn't fully explain that. And then the My Maternity, My Way attendance is the key group, that engagement group, and the metrics there show how that attendance has increased over time. Hopefully that picks up your issues.
That's helpful, Steve. I don't know, Val, did you want anything you wanted to add on that?
And just to say that we do have a go live date subject to the final testing next week, to ensure that any women undergoing loss during their pregnancy journey get taken out of the ongoing questionnaire, because it's a 4-point questionnaire. So we're live testing that next week. So we are hopeful of a go live date of the 9th of July, August even.
Right, okay, thank you very much. I think a number of colleagues are wanting to come in. So Jane, we'll go to you first, and maybe Jane, you could perhaps also just explain to colleagues how the Quality and Safety Committee has been interacting with this as well.
Indeed, thank you, Marcus. Clearly, the whole issue of the maternity and neonatal improvement programme has been strongly on the quality and safety agenda. And until recently, we received a lot of assurance simply through the Maternity and Neonatal Improvement Board, MNIB. But now we have an additional level of assurance because in advance of every MNIB meeting, there is something called a MNIB huddle, which looks at the absolute detail of everything that is going on. So by the time matters come to quality and safety, there's been an intense amount of consideration and scrutiny of progress against the various milestones that we have. We're slightly out of sync this time round, because quality and safety in fact meets in August rather than immediately before the board. But on our agenda there, we will have a full description of the new structure and discipline which Steve has brought to the programme as programme director. Val and her team have done sterling work over the last few years in addressing the objectives. what Steve's bringing to us now is a program management approach, which can really help us focus on the key things that we need to be achieving. And that includes setting out a roadmap with very clear milestones, which is something that IMSOP and Welsh Government have actually been asking of us for some time. So I know Val and colleagues feel very supported by Steve and his expertise in this. So I'd like to give board some assurance that we are very closely scrutinising this at Quality and Safety, that we will consider in some detail the new programme approach at Quality and Safety's next meeting. I'd also like to note that we have here data on progress against the Royal College's recommendations, which shows progress, and it's good to see and hear that we are continuing to make progress on addressing the recommendations. And again, we are taking a slightly more structured approach to that in terms of grouping together common recommendations to make it more straightforward to address them. I know, Val, that we continue to undertake work on the serious incidents, which are described here as the SI backlog. Could you give us a feel for where we are with that? Because we are very conscious, as you and I have discussed recently, that each one of these involves women and families.
Thank you. Yes, so we are now working very closely with our DU colleagues who have been commissioned to work alongside us in respect of serious incidents in maternity and neonatal services. We're very appreciative of the support and also the support that's coming from the central team. We've already identified fortnightly closure and assurance panels and have those in a forward plan with all SIs identified against specific closure and assurance panels, and we're looking to be completed through those assurance panels by mid-October. Alongside that, so our first panel is tomorrow, and we're also having a learning event on Monday. And where DU are being particularly supportive is supporting us to cluster similar incidents. And we're able to do that because these cases, most of the cases, are almost at completion, but it enables us to do learning in a much more rationalised way. So those learning events will also be repeated. Our colleagues have also been sitting in our current incident, local incident and senior review incident meetings, as have our IMSOC colleagues, and we've received very positive feedback around our current management processes. So we feel very energised by the support that we've got. It's been a long haul, a lot of work has been going on that's enabling us now to make apparent rapid progress. So we're very supportive. It's really generated some robust conversations in the service, but we're getting the right people around the table as a result of that. So hugely appreciative of the support from both the Health Board and the DU.
Thank you.
Thanks, Jane. I've got now waiting to come in Nicola, Patsy and then Jim. So Nicola, we'll come to you next.
Thank you, Chair. Thank you, Val and Steve. The Chairman's already asked one of my questions, but my other question is around the quality and leadership management. I know there's some culture work being undertaken in some surveys, and one of the key risks there is unclear workstream objectives. And I'm just thinking that some of the survey results will make those objectives a little bit more clear. And one of the initiated surveys from May is a snapshot survey. So I'm just wondering, when do you think we can expect to see some initial feedback from that survey, which will help to inform our work streams and our plans moving forward?
Thank you, Nicola. very timely, because this morning I was doing some analysis on the snapshot survey, so that has closed. They were right in the middle of doing that analysis. I'd expect over the coming weeks you would start to see things filtering through. I don't want to go into detail, but there are some positives, there are some things to address, and there are some differences on the different sites. So we need to look at that, and then from that drive those objectives, as you rightly say. That and one of the reasons for highlighting the risk is to make sure that we take that snapshot survey and other work coming through, because there's a really important piece of work being done by Claire Wright, which is much more in depth. The snapshot was only meant to be a very high level short survey that would give us some indication. The real richness in what's happening in terms of culture comes through the Claire's piece of work from Howell's team. Is that helpful?
It is. Thank you, Steve. It's just that initial bit that will get the work going, isn't it? Thank you very much, Steve.
Thanks, Nicola. So we've got Patsy, Jim, and then Paul. Patsy.
Thank you, Chair. Steve, I appreciate the balancing act between having a report that is succinct, that's easy to read and informative, but it does have to provide enough assurance to the board. And I'm not sure that I'm getting enough of a level of assurance, recognising that this is a very easy and succinct report that I can see. So in particular, my questions, I've got 3 questions, and one has been half covered already. For the next steps, I think we need to see dates. I think Jane referred to that as milestones, but I think we also need a time frame linked to that so that we've got something to monitor against. The completed actions, they just simply say completed. And I think we need some evidence of what has happened to enable those actions to have been completed. And incidentally, that's something that Reese referred to in the HIW report earlier. I know it wasn't connected with this, but it's the same governance requirement, really. So some evidence of that. And then following on from Marcus's very first point, it lists some pretty significant key risks, but it doesn't give us any indication of the actions that are being taken to address those risks and what's going to mitigate those risks in the short term.
Steve, do you want to reply to that?
Yeah, that's fine, thank you. And it comes back to the initial comment. Really, it's about get that balance right, and I guess for you that's not quite right in this particular report. I think in terms of assurance, as Jane outlined earlier, there are layers through this. So there's a MINIB group that goes through a lot more detail. There's a MINIB huddle that goes through even more detail, particularly around the programme aspects. Then there's quality and safety, and then what's come to board. Definitely, I can respond in terms of we can look at how we can clarify some of the issues that you're asking for, either through those layers or in the progress report that we bring here. And I hear the message from a couple of people that perhaps we haven't got that level, particularly around risks, quite right. So we need to probably expand that a little bit so that you can see the actions, etc. I don't really want to give you the full report, otherwise we'll end up producing lots and lots of material. And I think in board we need to keep it as sharp as we can, but you need to be assured that the process that we're going through is challenging, and the data, and that you get to see the things which are critical, either whether that's positive or whether that's something that we need to address. So I understand that and hear that loud and clear.
Okay, thanks, Steve.
Thanks, Patsy. Steve, just on that, I would sort of, I understand what Patsy's saying. Really, I think this is really helpful. 3 pages that gives us a clear overview is really valuable. But I think perhaps, given the complexity and the seriousness and the priority that this gets, maybe it does need behind that a bit more detail for those who want it, so that we can see the wood for the trees. But if we want to look at individual trees, you know, we can find them, as it were. So maybe that needs a little bit more thought offline as a sort of further development of this. Something along those lines would be helpful, I think. And I was also just reflecting on Jane's point about the slightly unsynchronized time this month with the Quality and Safety Committee as well, because maybe that's part of the picture as well. So perhaps if we could ask you and colleagues just to continue to have a little bit of a think about that, and to see what else we can do, but certainly not, you know, don't drown us in data that won't actually help. Jane, did you want to come back on that particular point before we go to other colleagues?
Yes, please, Chair. I think the point about the Quality and Safety Committee actually at its next meeting having sight of the structures that we're talking about will be really helpful. I mean, there we will get actually to look at the roadmap and to understand the new structures within the programme and the terms of reference of those and how everything fits together. And I think that would give all members of the Quality and Safety Committee the ability to share that assurance with the board. It's just that we're out of sync right now.
Thanks, that's really helpful. I don't know, Steve, whether you want to come back on any of that, or we've got a couple more comments to take. Anything you wanted to say particularly, Steve, or you happy just to take that offline and have a think about it?
No, nothing to add really. Just it's a constant challenge, isn't it, getting the information right, and not overwhelming you with lots and lots of data.
Great, thanks. But we'll leave it in your capable hands. That's excellent. And we come next to Jim.
Thank you, Chair. Steve, I missed probably 2 minutes of your presentation when I went on to the chat bar and got thrown out, so I apologise if you've covered this. Have we, a couple of questions, have we commenced a peer review of our service provision just to check the robustness and security of the services we're providing now in terms of patient safety? And the second question I wanted to pose, and of course if this had come to quality and safety first, we probably would have addressed it there, but I'm interested to see if there are any particular themes or trends, particularly arising from the clinical review findings into the stillbirths, to see that are there issues here, what learning has been derived from that, and to what extent have we embedded any changes into our service provision now, so that we try to minimise repetitions going through? Because I think the patients and the communities would want to be assured, as well as the board, that the service now is safer than it was, and that we're going in the right direction. This headline report is good, but there are limitations, as others have said. Thank you.
I'm happy to speak to that, Chair. So thank you, Jim. Just to say that alongside the improvement programme, we still are completing a weekly dashboard that covers many of those safety aspects of the service that has scrutiny by Welsh Assembly Government. We meet only monthly now, but we still provide a weekly dashboard with monthly run charts, which give very clear oversight of our clinical outputs and outcome measures. So that scrutiny remains ongoing alongside scrutiny of our improvement programme. That remains ongoing. We've recently been to an All Wales Performance Board that all maternity and neonatal services across Wales attend, and we are going to be presenting information on that in the next item agenda, where we will cover stillbirth within that meeting. We've recently had a peer review for supervision, which is a large part of our safety and improvement work. Again, an all Wales provision and all Wales peer assurance. We've had very positive verbal feedback from that, nothing written as yet.
Thank you. Thank you, Chair.
Thanks, Jim. Thanks, Val. Very helpful. And Paul, we're coming to you next, Paul Mears.
Thanks, Chair. I mean, just to say thank you to Val and Steve for this update. It's obviously a lot. There's a lot of work going on behind the scenes, and as I think colleagues have said, the report in its current form perhaps doesn't convey the extent of what's going on. So certainly I think it'd be useful to be able to bring a bit more detail back at a future meeting. My question was specifically about the reviewing of the SIs, and I know, Val, there's been some challenges in terms of getting the right people around the table to have that, and I guess it was just that point about the obstetrician input into SIs and reviewing those. Are we comfortable now that we've got the right medical support into that process, and that we've got in the right scrutiny from the medical perspective as well as the midwives?
Well, as you know, we've grown our assurance process with our medical colleagues, and we've got a very dedicated group of medical colleagues that are supporting us. In opening it up to assurance and review panels and learning events, that opens that even wider. So this becomes something that's relevant to every midwife and medical colleague, you know, so it becomes much less that this is managed within the governance hub, as we refer to it, much more business as usual, that this is to do with everyone. And as we're emerging from COVID, you know, we've got an opportunity now, haven't we, to bring people much more on board with this side of things. So we've had, you know, good engagement in reviewing our moderate and above harms. We've got lots of clinicians involved in that process. We have lots of clinicians involved in reviewing the findings of the external reviews. We have a clinical cabinet. So the culture of that being part of everyday business is really starting to grow. I'm not saying we're there, Paul, we still have a journey to go on, but this last endeavour has really, let's say, it's created a lot of conversations that have allowed us to kind of lay the train tracks for the direction we want to go in the future.
Thanks, Val. I mean, I appreciate this is all part of the cultural journey as well, isn't it? Not just about getting attendance at meetings, it's also about that culture of multidisciplinary, multi-professional perspectives on these challenges. But yeah, thanks for that. That's great.
Thanks, Paul. I mean, that's such an important point, isn't it? I wonder whether it's worth just bringing in, since colleagues are very kindly attending this meeting as well, Mohammed and Sally and so on, just to get I don't know whether any comments that they would like to make about this issue about. Because one of the most disturbing things from the original report was the examples where if you like, the medical community and the midwifery community were not working properly always together in the interests of the people that they care for. And we do know, don't we, from reports elsewhere in the UK, that this is unfortunately not an unusual issue. I don't know, Mohammed, you've appeared on my screen now, so it's you. Any thoughts on all of that? Because it's one of these sort of intangible but desperately important issues, isn't it?
Yes, thank you for giving me that opportunity, and really it's a very good and valid point. And since I joined CampTAF in 2019 till I become now the CSD, we are working so closely together with the midwives. Myself, George Harun as Labour Ward Lead and Ihab as Risk Management Lead are working so closely with Val and Cassie, and we are doing these regular catch-up meetings in order to look at the service from both obstetrics and midwifery point of view and help to manage that. And even within the ILG structure now, the Tranvit is myself as a CSD, Cassie Greaves as Head of Midwifery, and Chris Moss as Directorate Manager, who are doing that fortnightly catch-up to look at the service. Regarding the incident reviews and SIs meetings and the NDT approach of it, now we have, as Val said, a very valid structure about that reviews, which involves obstetricians, pediatricians, midwives, governance team in 3-tier systems. So the first one, which run on Wednesday afternoon, which we call it the incident NDT review for obstetrics, which includes a Labour Ward Lead and the governance team plus Band 7 midwives. Usually attended by the risk management lead and myself at some times, and then this will be escalated. Any moderate and above goes to the senior NDT team, which includes a CSD on both sides, head of midwifery on both sides, VARA's Directorate of Midwives, and the governance team. And then any other issues which need to be actioned or escalated will be reviewed at a separate meeting between combined the medical team and the midwifery team, in order to make sure that all actions are discussed in an MDT approach, and we have some sort of assurance about what we are doing in that MDT approach for women and patient safety.
Thank you. That's very helpful and reassuring, isn't it? I mean, I guess we're in a situation where this, we haven't cracked any of these problems in a way, because they are not. You don't crack things like this, do you? They require constant focus and attention. But it is very encouraging, I think, to hear about the progress that's being made. Good. I'm just looking to see whether anybody else is going to come in. I don't think there are. I think we've covered everybody's questions. So I know we're going to carry on just to the other bit of this, the new set of data, Val, but I think that I can speak on behalf of the board. We would again want to thank you and particularly your teams, all of your teams, everybody involved in this. And I know we're talking about, hundreds of people when we say this, for everything that you are doing on this area. This is, at the very, very top of our priorities as a health board, has been now, for a couple of years or more, and will remain so. And it's very encouraging to hear that you're getting the support that you need from the organisation and from all involved. So it's a warm thank you for the hard work that you're continuing with. And we're taking and will continue to take a very lively and close interest in this. So thank you very much. Perhaps we could just come on then to the next little item, which is like a sort of sub item to this, but really quite important, I think, isn't it? Because we've been looking for comparative data, some reliable and objective evidence on the key issues, and it looks like now it's beginning to become available. Over to you.
Thank you, Chair. So yes, just by way of background, in Wales there is a yearly performance board, I think previously called the JET boards, that all maternity services attend annually, and obviously that was stood down during COVID last year. They have been refreshed in terms of their process, their inclusion of neonatal colleagues for the first time, also in terms of the measure. So it is very much replicating now the weekly and now monthly scrutiny that we have been undergoing with our Welsh Government colleagues as part of their oversight of the safety of the service. So we felt quite well prepared as we moved into the performance board. So today is a very brief summary. There is much more data available if anyone would like any more detail afterwards. But I'll hand over to Mohammed now just to introduce the start of the presentation. Thank you.
Thank you, Val, for that. I'm not sure if I can share the presentation from my screen.
I believe the presentation is ready to go.
I can see it actually.
Mike, are you able to help us with this?
Yes, I am. Which presentation are we looking for? It's the maternity?
Yes, that's the one, Mike. The one received from MAS today, 5.31. Thanks, Mike.
Yeah, here we are. Okay. So first, I would like to thank Val and Cassie for their hard effort and work and preparing that presentation. It's all their work and efforts, to be honest. and all the numbers and the performance that is amazing. So really, I much appreciated the work done by Val and Cassie about that. Next slide, please. So today I'm going to give you a very brief overview about our performance data. As you all know, Welsh Government hold an annual maternity and now combined with neonatal performance review. Our agenda this year had changed dramatically compared to previous years. And this was very much to mirror the Welsh Government weekly review for CTM. And this based on our current special measure status. This measure is being used to hold the other maternity service in Wales to account, enabling the local and national benchmarking in Wales. Our last annual performance review was in 2019, of which the follow-up letter requested the Service and Health Board concentrate on some areas where performance could be improved. So we will go today through the performance board agenda, which is update from 2019 progress report, neonatal and maternity COVID reflections, our key performance data, additional requested data, clinical supervisor for midwives, neonatal data, governance discussion, safety and training, engagement on and family, and future service plans. Next, please. And I think now I will hand over back to Val.
Thanks, Mo. So this was, these are the areas that were highlighted by the CNO from the 2009 report. These were some of the significant actions that the service was asked to look at. So in particular, one of the issues was that we weren't having our initial visit with women and families by 10 weeks. And that's really important that we get a pregnancy journey planning off to an early start, particularly with the demographic that we have within our service, and we have a lot of complex care and comorbidities, so it's essential that we get those bookings. And I'm pleased to report that despite the pandemic, you can see that we are now achieving that target really well. We're not able to always do them face to face anymore, I'm afraid, but we are starting to reintroduce that as it's safe to do so. Breastfeeding we will come on to talk to about in more detail. It is a significant challenge within the Health Board, but we have had a position of always having the lowest rates in Wales. What we're starting to see is a year-on-year improvement, but Kathy will speak to that later as we go through some of the public health improvements that we're making. Next slide, please. Of significant interest to our regulators have been our caesarean section rates and our induction of labour rates. And it's a challenging conversation because it's not about reducing rates, it's about appropriate decision making to ensure safety. And we know there is a relationship between, you know, artificially lowering induction rates and rising stillbirth rates. So, you know, these aren't simple things to look at. We've engaged with colleagues from Improvement Cymru to absolutely make sure that the initiatives that we are taking are the right ones. I think that, you know, the graph speaks for itself, that, you know, our rates are now absolutely comparable. But the important thing about that is it's all placed around decision making. It's not just about improving rates. It's about working with women to understand their wishes, make sure they have the right information, so that we're arriving at a joint decision about the safest way for a woman's birth. And that's also true of induction. Induction has been a particularly challenging one for us because so many of our women have comorbidities that would put them into an early induction bracket. So that's always a challenge. But we actually, for a significant amount of time, reviewed every induction to make sure that it fell within our guidance, and where it didn't, we challenged that decision making. But again, that's also about working with our families and our women, and we've also done quite a significant piece of co-production with our user group, My Maternity My Way, around how we share information with women. Next slide, please. Incident levels were felt to be low. We've had recent assurance from our DU colleagues who are now reviewing all of our incident reporting every week, and they are assured in terms of the numbers we're reporting, the reasons we're reporting, and our assessment of harm. So that's really good assurance that things are now where they should be. We enjoy really high levels of reporting, appropriate reporting, and part of the work that we're doing now is improving feedback, so the feedback is much more meaningful to staff and more timely. Next slide, please.
Thank you, Val. So I think one of the things that's very, very important that we must remember whenever we're looking at outcome measures in maternity services is outcome measures or rates are just simply that. What's very, very important is the experience that both our staff, our families and our communities receive from our services. And COVID did present particular challenges in trying to support some of that engagement in lots of different areas, but we had to get very creative in how we were doing that to celebrate some key milestones, such as International Day of the Midwife, which we shared with our nursing colleagues for the first time this year, a very successful event in which every member of staff was recognised for the contribution they make to our service. They were gifted some gifts which were really gratefully received. But equally, on World Kindness Day, the staff in our areas actually went out and put together support packages for women whilst they were in hospital with us to ensure that they experienced the levels of support required, with their partners not being able to have access to our clinical areas. We've celebrated how our babies are born into the world and shared that with our local communities. And some of the things that we've been using, like our infographics and data that talks to our communities about how we're doing in these areas, have been so popular. We had to backdate them to the beginning of January 2020 at very many requests so that they could have those as part of their memory boxes for their birth and for their babies and children as they grow. And what we've seen is that traditionally, when we have open access to our ward areas, you'd go into a ward, it'd be very dark because curtains would be around beds as partners were with us. That has changed dramatically throughout COVID. The curtains are wide open, the women are interacting, they've created friendship groups, they go to many different events with the babies, and the bunnies that you see on the image there are actually our mothers, our babies, who are having events outside of and joining in with maternity to celebrate birth at Cwmtaf Maganog. Thank you. Next slide. Okay, so there's lots of data, as you can imagine, but what we thought we would concentrate on are some of the areas that actually impact on outcomes for our areas. We do know that, as you can see from the graph, anything in green represents Cwmtaf Maganog. We have the highest rates of obesity in Wales, something which has a dramatic impact on healthy pregnancies, healthy birth and outcomes for mums and babies. We are very fortunate that we have a programme called Bump Start, which has been in what was Cwmtaf for many years and now has migrated over into Bridgend as we've moved the service forward, so that we are supporting women with the particularly large BMIs, around 40, to help them throughout pregnancy to try and maintain healthy pregnancies and also then to achieve good outcomes. And I think some of the headlines that I would like to just draw your attention to on this one is that we try to get women to not put excessive weight on in pregnancy between 5 and 9 kilograms. And as you'll see, the programme and the way it's delivered by our midwives is achieving 5.1 kilogram average weight gain in pregnancy. Very important, this group of women would normally traditionally have a higher rate of low birth weights, and of the population of the 40 and above, you can see that the low birth weights account for 2% because they're getting that support in pregnancy. But also the cesarean section rate in this overall group is not as high as you might anticipate, but particularly for those women who've had previous births, we're achieving 93% of that population achieving a vaginal birth at the end of the pregnancy. So it's a fantastic service, it has really great outcomes, and we're seeing that in our data despite having those very, very high rates of obesity. Next slide, please. So again, smoking, which has a huge impact on pregnancy, and we have the MAMS programme, which is the gold standard. It was trialled a few years ago with Public Health Wales using different models The most effective model was the model that Cwmtaf Morgannwg tried, which was using healthcare support workers providing support throughout pregnancy for women who would like to make a quit attempt. You can see that, you know, in terms of the women who were initially assessed as smokers at birth, Cwmtaf's right at the top there. But by the time we get to the end of pregnancy, for those women who are engaging in our services, we get a 10% quit rate, which is then identified in the second graph, which is showing smokers at birth. Next slide, please. Breastfeeding rates, we do have the lowest breastfeeding rates in Wales. The graphs at the bottom will show you those women who exclusively breastfed at birth, those at 10 days and those at 6 weeks. Now, although we have the lowest rates in Wales, we've seen for the last 5 years a year-on-year incremental increase so that we are catching the other health boards in Wales. But actually, overall, when you look at those graphs, we are seeing that whatever we're doing, we're having the best trajectory of improvements in breastfeeding. So it's really encouraging. We have just lost our infant feeding coordinator who's been with us for many, many years, who's now retired. So we're out to recruitment currently to replace her. But we do have that provision still within the health board, because we also have an infant feeding coordinator who works over on the Bridgend ILG, who supports us here on the Merthyr Cynnon ILG in delivering our action plan. And we do have a breastfeeding action plan that sits alongside BFI accreditation. We're due for re-accreditation. We're working through the action plan right now to set a date for when that will happen. But we're really excited that we're working alongside My Maternity My Way and gaining experience from the women who've used our services and what that needs to look like for them too. Next slide, please. Mo, this is over to you. Thank you.
So this slide is mainly about the cesarean section birth rate in Cwmtaf and compared to Wales regarding the all cesarean sections, and we divide it into emergency and elective, which is reflective to our way of management of our women and how we can treat them appropriately to improve the quality of care provided to them. And despite that, we have some quite high rates initially. The rates are dropping throughout the time without any effect on the quality of care provided. I would like to highlight the attention that since 2019, we developed two main working groups, which is cesarean section working group, which is led by antenatal lead Helen Marks, and the induction of labor working group. And both of them are working closely monthly basis to review the data and the quality of the process. Because we believe it's not just about a number or a rate, because when we start looking at our rates initially, yes, we were high, but it's high because our population have their specific demographic criteria which require that high rate. So any comparison against other health boards may not be fair to our trust, because we need to do the management which is fit to purpose, and this was reflecting to our incidents at the end and the safety of women delivered since 2019 till now. We have no harm happened as a result of a cesarean section or an induction of labor decision. So we are working on a different way, which is improving the quality of the process as well, not just about the number or trying to reduce it, because safety comes first. And this was quite clear in our emergency cesarean section rate, which is only 12%. So it's not, we're not outlier in that. And our elective section rate as well is 15.4%. So the graphs themselves, I'm sorry if they are a bit small, but the graphs themselves are descriptive of where we are in compared to our health boards, taking into consideration the fact of the demographic criteria of our women and the quality of process, which is running an improvement trajectory since 2019 so far. And now we have a cesarean section improvement group, which is working across the CTM, including Prince Charles as well, in order to look at how we can improve the quality of a cesarean section for women and how we can improve their experience. Next, please. Next again, please. So again, back to you, Cassie.
Chair, I think we may have lost Kathy from the call, maybe due to technical issues.
Okay. Mo, are there any other slides that you can cover, or?
Yeah, I can continue to Cassie's back, that's fine. So this slide describes about the stillbirth rates, and as you can see in the chart, we are not outlier in comparison to other health boards. Indeed, we have a good trajectory of improvement through reducing the number of stillbirths, and actually all these stillbirths now are discussed seriously, and actions are being taken in order to make sure we have the learning events out of it, and we reduce any avoidable event if any is present. As well as we work closely with My Maternity My Way and engaging with the women, showing the posters about what we are expecting from the public and population in order to help. For example, making my movements matter. It is very important to highlight this fact that when the woman is experiencing any abnormality in the fetal movement or any change in the behavior of the baby, she should highlight that to the maternity unit as soon as this happens. And we invite them to the department and we start doing the investigations appropriate to her complaint. And we managed to save a lot of babies out of that. Just this poster, we're increasing the public awareness about the importance of a simple issue, which is movement of the baby, and how we can monitor that and how we can act on that. Again, Bump Start is doing a very great work about improving the stillbirth rates and reducing it through the improving the preconceptional services. And even now, we are starting from September, the preconceptional service, which is something we are inviting the public and the women who have any health problem before pregnancy to come and see us in a combined approach with our medical colleagues, so we can make sure that the pregnancy happen in the optimized clinical condition, which we are sure that will help a lot to reduce any pregnancy-related complication out of the pre-existing medical problem, and accordingly will help to reduce the stillbirth rate. And all cases, all women who have suffered from stillbirth, sadly, we discuss all these conditions in our PMRT reviews and make sure that it is actioned and all actions are taken taken seriously in order to improve the care and to get any learning events. And this is shared with all the staff as well as the woman involved in the report when it is present. Next slide, please.
I don't know whether Kathy's appeared on my screen. Are you with us, Kathy, now? No, perhaps not. Mo, can you carry on?
So this slide describes about the Camp Taff Morgana maternity and the celebration which happened, and the pride we feel when we help our woman to get baby. Always birth experience is a very important experience for the woman and for us as well, to celebrate the birth of new babies and the safety of the woman. We choose obstetrics in order to see this smile which we found on the faces. This actually is a reward which we get when we have the woman safely with going out of the hospital with their babies coming out. And we would like through this slide to share with you all the positive events which happened in real time with the woman delivering their babies, and thank you which came to our. And I'm sure you are all aware about the recent article which came in Wales Online about a woman who delivered safely in our unit, and she showed her gratitude to all the teamwork and the efforts done in order to save her and deliver her safely. It was a bit of a complicated situation, but because of the teamwork and team efforts, all done safely, and the woman managed to go home with her baby in a complete safe condition. Next slide, please. So our future service plans is to continue and maintain the improvements happen. This is not the end of story. Our plan is to be able to fulfill the whole Wales maternity vision, which is family-centered care, safe and effective care, continuity of care, skilled multi-professional team, and sustainable quality service. And I have to admit, this was my aim since I joined Camp Taff in 2019, is to deliver a safe, effective, evidence-based and multidisciplinary care for our women through engagement with them. I believe our women deserve the best of care, and at the same time, the feedback we receive from our women is our driver to shape the future of our service. And this feedback is done through my Maternity My Way. We are developing all sorts of engagement channels in order to be able to reach the woman. This happens through virtual tours, through video links. You can look at our Facebook page, which we are every now and then doing video links about it. And even we are planning as a senior team in the future to have a regular senior team video links where the obstetricians as well as head of midwifery and directorate will deliver messages to the woman in a public way of engagement in order to engage more with them and encourage the feedback. I would like to reassure all the public that we are learning a lot from all the concerns, from all the claims, from all the positive and negative feedback. We all take it into account in order to improve the care provided, and this will drive our path forward for our future service plan. The maternity version lies within the ILG structure. So the ILG structure combines now obstetrics and gynecology in order to make sure that we provide a full comprehensive care to our women, which fit to the best quality care can be provided to them. Breastfeeding Action, as Cassie spoke before, we are dealing with that in order to get the breastfeeding initiative in Prince Charles Hospital. And we are working with the future regulation health plans through the preconceptional services and the ILG version of preconception 2,000 days after. And we are going for a recruitment of an improvement post supporting the work of that network. Next slide, please. So thank you for your time, and now I'm happy for questions. And sorry for the last 3 slides. I'm sure Val and Cassie will speak much better than me about them because you're preparing a lot of stuff. But I started.
You did an excellent job, Mo, and very nicely demonstrated the spirit of multi-service, multi-discipline, multi-professional service delivery. It's excellent. That's been extremely helpful, I think. There's data there that we've lacked a bit, I think, in our discussions over the last months, and it's very useful to flesh out the whole picture, isn't it, of the service, and to give us a good sense of it in the round. That's really helpful. And I'm particular thanks to Kathy and to Val, who were sabotaged by the technology. But I've got a feeling you're lurking there somewhere in the background, at least listening to what's being said. So can I thank you very much for that? Can I ask that those slides are circulated, because it was quite difficult to see some of the detail on the screen. It was a bit small, but I'm sure, Callie, you can circulate that amongst colleagues, because it would be of great interest, I'm sure. Thank you very much. So thank you very much. We spent a lot of time on maternity service this morning, for which I'll make absolutely no apology at all. This is a really important area, and it's very important that the board understands what's going on and owns the issues and is able to provide whatever support is needed to Mo, to Val, to Kathy, and to everybody else who is doing a fantastic job at transforming the service. And we're very grateful to you all for that. Thank you all very much indeed. Colleagues, I'm going to propose that we have our 5-minute break now. We're a bit late, but I think we probably need a 5-minute breather. So on my watch, it's 7 minutes to. So if we can come back together at 2 minutes to 12. Thanks very much. Right, colleagues, thank you for coming back so promptly. We'll press on with the agenda. The next item is 5.4, which is the continuous improvement self-assessment process related to targeted intervention. And I think Richard Morgan-Evans, you're going to present the report. Thank you.
Diolch, thank you, Chair. Hi everyone. As the Chair said, this is focusing on organisational-wide targeted intervention and the sort of a progress update of where we are and what our sort of next steps are. The paper in the reading pack really just sort of formalises the feedback and output from our recent TI self-assessment board session on the 21st of June. For those watching that are not familiar with that format, essentially sort of every other month we get together as a board plus, I would say, so the board plus sort of integrated locality group and system group colleagues, and really sort of take stock and scrutinise where we are on our sort of targeted intervention journey. It's a good and useful sort of forum, and it means that we can sort of focus a lot of time on sort of targeted intervention and how we're doing across all of our sort of 13 domains. Just for wider awareness, really, we also hold a sort of monthly working group to make sure that we've got sort of good passage of information across the whole organisation with respect to this sort of topic, as it really is so broad. In the paper, if I can draw your attention to the three sort of maturity matrix sort of heat maps across sort of leadership and culture, trust and confidence, and quality and governance. And it shows that we have been making sort of steady and good progress over the last sort of few months, which is great to see, and it's great to sort of be able to use the Vice Chair's words earlier, triangulate what we're sort of doing as we sort of move through. As you'll see, we're pretty much almost, apart from one or two areas, in sort of level 3 results phase now, which is great. It means that we are achieving sort of early sort of improvements, and we're seeing results across some different sort of areas, and that's something we want to build on over the next sort of few months. From a leadership and culture point of view, there's a lot going on, you know, management, leadership training, obviously a lot of work on culture, as well as sort of employee experience and things like that. Trust and confidence is a big area, and you know, are we communicating with our sort of staff, our public? Are we engaging and involving them? And just yesterday, you know, we held a sort of a health board wide leadership forum for all managers, sort of band 7 and above, to be able to get updates directly, hear feedback, ask questions, which is a great thing, which I'm not aware actually takes place in any other health board in Wales. So it's great that we're doing that. And quality and governance, so making sure we've obviously got good governance, good risk management, quality and sort of safety issues are being sort of dealt with, and quality improvement is very much at the forefront. So it covers a whole range of areas. So these sort of forums pull it all together into one sort of neat package to best sort of take stock of it. I'll also draw your attention to the forward plan or sort of forward roadmap, and actually since this one in the appendix was submitted, we have actually extended it to the end of the financial year, and that's obviously an iterative process. We're constantly looking at updating it. Members will see it's a busy plan because there is a lot going on, but we've tried to include sort of aspirational targets and milestones within that to make sure that we're keeping ourselves on the straight and narrow. We're not just thinking about what's happening on the next day, the next week, but we're thinking about what's happening over the next month, 3 months, 6 months, 9 months, to make sure it's a improvement sort of journey that's not just about the short term. Just sort of quoting sort of Dave Thomas from Audit Wales earlier about an outcome focus. This isn't about ticking boxes, and we need to sort of ask ourselves, so what? So, you know, we're doing a lot of good activity, a lot of sort of change initiatives. What are we seeing from that? How many people are attending? And what's the feedback we're getting? You know, is it cascading and spreading through the organisation, building a sort of a learning culture and things like that? So as we sort of look forward, our next self-assessment board is on the 16th of August, so a couple of weeks' time. We're going to be sort of, you know, focusing on the benchmarks. What should we be seeing in some of these key areas? What activity are we doing? But thirdly, what are some of the outputs? What's the so what, or the indicators of change, as some people put it, to make us have a level of assurance that some of these sort of aspects of work are really taking hold. And then as we get to the end of August, on the 26th of August, we'll return to Welsh Government and speak with the Welsh Government colleagues about our progress with TI as well as special measures. so we can best showcase and understand what some of the next steps are there. So I would say thank you to everyone from board members down for their support on this. It really is an area, it's not a specific area, it's an area where everyone plays an ongoing role. But also thank you to Welsh Government for their sort of constant support and advice as we've sort of gone through this journey to be able to check things with them. And I know they sort of work with us closely, and we sort of share information and evidence, and including at the self-assessment board. So within the pack, within the appendix, there's a plan on a page there, which again is an iterative thing, which does get continually updated. We put a governance sort of timeline in there, and that's really just to show the behind the scenes mechanics of just sort of managing this improvement program, because there's a lot of forums and a lot of bits and pieces we need to make sure we hit right, so we can keep up the momentum and pace really. And then we've also shared the June targeted intervention sort of slide pack, just showing some of the discussion sort of areas we were having. But it's great to get sort of a good level of scrutiny from independent member colleagues, as well as executive directors and the wider sort of workforce that attend, to be able to contribute towards this. So I'll pause there, and this paper is asking for an approval of that sort of level of the level of self-assessment before we obviously move on to having another look next month. Thank you, Chair.
Thanks very much, Rich. That's really helpful and very clear. And in a sense, this is almost like the culmination, isn't it, of a whole round of assessments which have involved independent members on more than one occasion, actually. So but it's very good to see the whole thing brought together. And I guess gives us an opportunity here today to do a couple of things. One is to say, is this evidence-based? And secondly, does it feel right? Because sometimes you can focus on the component parts and are sometimes misled in terms of the whole. So thank you very much. It's very helpful and very well presented. That's really helpful to us. Colleagues, any questions or any comments that anybody wishes to make? I'm looking at the chat bar to see if anybody wishes to come in. Jane.
Thank you, Chair, and thank you, Rich. This approach to looking at how are we tackling the issues within targeted intervention and indeed special measures is very, very clear and very, very thorough. We're a large organisation, and it would be easy for our activities in this area to drift. We'd be doing lots of stuff all over the place, but would it actually be focused on delivering the outcomes that we're looking for? With the approach of contributions of independent members into assessing where we are looking at the detailed evidence, which then feeds into the targeted intervention board, and then is consolidated into this for board, and indeed having a plan on a page, which I think is a remarkable achievement, given the amount of activity going on. I think this gives me real assurance that we are heading in the right direction, that we're scrutinising evidence thoroughly, that we're not fooling ourselves by being over optimistic, and we're still self-critical. And there will be a lot of challenge ongoing, especially in the TI boards. But I think this is a fair representation of where we are based on evidence, and I'm happy to support it.
Thanks, Jane. That's very helpful. Paul?
Thanks, Marcus. I think just to endorse what Jane said, I guess, the challenge with all of this is there's a lot of work going on in this space at a time when we're also very, very resource drained on lots and lots of other things that we're doing as well. And I just think it's really important to recognise that this is still a fundamentally important part of what we do, what we're doing as an organisation in terms of our improvement. And I think we've had a lot of change in the past 12 months or so, as well as dealing with the pandemic. But I think what for me is assuring is the fact that the programme of work described in this plan is continual. It isn't reliant on individual people people or or individuals to sort of drive their work forward. It is very much owned and shared by the whole exec team and the board, which I think is a really important thing. I'd also say, that it's the usual thing about continuous improvement, isn't it? This is never there is always going to be improvement. No matter how good we are on the maturity matrix, there will always be things that we could do better. So I think we've also got to remind ourselves that this is always going to be a journey, and if we're very much now focusing our efforts as an organisation on how we continually build that culture of improvement across the organisation. And I guess it's that recognition that the work will always there will always be further work to do, but what we I think can take assurance from this programme is that a number of the key sort of planks, if you like, of that future are very much now embedded and in place. And certainly for me, on a sort of first-hand level, I do get a lot of feedback from individual members of staff out and about saying they feel that things are moving forward, they feel things are different, they feel that the culture is changing, which I think is really positive. Yeah, that's not to say we haven't got a lot more to do, but I think it is an encouragement to get that feedback, and I think also sets us in a good position as we particularly move into the area of developing our strategy and that next strand of work, which will obviously be a key part of our next stage in our development as an organisation.
Super, thanks, Paul. So colleagues, we're asked to approve the level of TI progression that was endorsed at the self-assessment board a month ago, and to support the ongoing improvement plan. I can see from comments in the sidebar that people are supporting that. So yeah, that's great. Thank you very much indeed. And Richard, thanks very much indeed for that. We'll move on then to item 5.5, which is the highlight report from the Clinical Advisory Board. Anna, very warm welcome, lovely to see you. We've got the report in front of us. I guess also it would be quite interesting to hear from you your take on what it is you're trying to achieve in this group and how's it going. Over to you.
Thank you, Chair, and thank you for the opportunity to talk. If I may just take a minute or two to introduce myself. So I'm a respiratory consultant working at the Royal Glamorgan Hospital. I trained and worked in England for as long as I have worked in Wales, and I have the privilege of saying that I love my job, never more than working here actually in Queen's Health Morgannwg. It is a real privilege. But there are frustrations, and I think I just want to highlight two frustrations that as a clinician in the NHS, I've experienced, not a reflection on this health board because they've been sort of frustrations throughout my career. The first is that we do feel a lot of the time what we do in our clinics is applying bandages when there is a sort of metaphoric dragon out there in the community ravaging through our population, made up of the deprivation, the childhood disadvantages, the unhealthy lifestyle choices, mental health problems, and the sort of disempowerment of our population. And I think we all recognise in our clinics that we need to tackle that dragon out there, but that's an overwhelming task. It's a long-term task, and I think we all worry about how do you resource the army you need to tackle that dragon when you're spending all your resources just trying to keep on top of the bandages required to treat those injuries. And it's something that I think the public health agenda, the population health agenda really starts to address in a way that inspires me. The other thing I think, unfortunately, is that we do have a them and us culture in the NHS, and I think we probably have that. It may be something that is in all large organisations. We advocate very strongly for our own patients and our own services, but we see on a day-to-day level a kind of medics versus surgeons, the primary versus secondary care. In between the ILGs, there is now sadly sort of inter-ILG competition, and between us as clinical staff and our managers and you as our board, there is a sort of lack of seeing ourselves as a whole team with a common goal. And I think the only way really of tackling that is to improve communication, and so we all get a better understanding of what we all do and why we make decisions and why you make decisions on strategy that you make. And the more that we as the clinical teams can understand that, then I think the better we'll work together. So I'm really enthused by this current drive by our board to improve this communication with clinical staff. The sounding boards, the CAG, the question and answer sessions, the leadership forum are all fantastic examples, I think, of that. So just moving on to CAG. So we have members across all 3 ILGs in community, primary and secondary care. We've got nurses, midwives, allied health professionals, psychologists, GPs, consultants in hospital, scientists, dentists. That doesn't cover all of the diversity of the group, which is obviously one of our big strengths. So we had our initial sort of meeting and agreed our terms of references, and we're really lucky to have Fiona, who has agreed to be our exec lead and support, which we're really privileged to have. We've also had Linda Prosser attend our sort of meetings. She's been really engaging CAG and getting involved in strategy work stream, and the CAG accepted the draft strategic goals for the health board and raised some concerns and received some reassurance about deferral of service improvement. We've had Kelechi join us at one of our CAG meetings to introduce the population health strategy, which generally is extremely well supported by clinicians. There's a big recognition, as I said, that the conditions we see have common upstream causes that we don't feel empowered to tackle, such as mental health problems. And also there's a real feeling that our children need to be one of our biggest targets, really, in changing the inevitability of their life course whilst they're still young. Interestingly, there were some concerns that the population health strategy outlines 5 key conditions, which are sort of the conditions which lead to the most loss of disability adjusted life years. And people worried that if their service wasn't mentioned in those 5 conditions, did that mean that their service was going to be devalued? And Kelechi had some work to reassure CAG members that wasn't the case, and I think that communication needs to be widespread as the strategy becomes more widely sort of engaged, because I think that will be a common theme coming from clinicians is if their condition isn't mentioned, then are they going to be devalued there? And then again, as I sort of alluded to from my personal experience, there was again this concern about how do we agree with the Welsh Government position that in the long term, health needs to move to the communities, it needs to move closer to home, and there needs to be less emphasis on secondary care. But how do we do that when we're constantly firefighting the demand that we get in secondary care? Clinical Sounding Board has also had some really interesting conversations. They looked at the population health strategy as well, and again there was a lot of enthusiasm. There was the suggestion that a lot of clinicians would like to tackle these sort of problems with ill health that they see in their clinics, but don't feel necessarily empowered to do so. So, for example, in an incontinence clinic where patients have a problem with their BMI, telling that patient to lose weight doesn't feel like you're really addressing the problem. Having a service that you can refer that patient to, being able to offer them support and help in doing that is really the key. And there was also a really interesting point brought up by one of our GPs, which is that our population have an unacceptable acceptance of their own life expectancies and their own disease profiles. So you can tell a man in their 50s that they have a terminal cancer, and they might shrug their shoulders and say to you, well, my parents died in their late 50s, my brother died in his early 60s. I didn't expect to live beyond 60, and that's so sad and is really something that we need to tackle. Our population should feel entitled to a good life expectancy. And similarly with diabetes, we get the situation where a patient's told they've got diabetes and they're, oh, well, you know, all of my family members are diabetic, all my friends are diabetic. Diabetes is an inevitability in my life. And so we just really want to be able to tackle that perception in our populations. At the last meeting that we just had last week, we talked a little bit about point of care testing, so bringing testing close to the community. And we highlighted the fact that there are some probably quick wins where we could really avoid admissions to secondary care if GPs had access to some simple blood point of care tests. Our scientists did highlight the fact that this is on the Welsh Government agenda at the moment, and we may find that Welsh Government funds some of the point of care testing centrally, and it may be that the Health Board wants to wait to see what Welsh Government want to sort of pursue from that point of view. But certainly that there are some simple tests that are of good quality now and reliable that can be done in primary care that would help GPs to make important decisions. Those tests, there needs to be connectivity to our clinical portals so that if point of care tests are done in the community that they can be seen. So there is some work that would need to be done before point of care testing could be increased. We recognise that point of care testing is also about other things such as imaging, radiology, and simple things like an ultrasound scan can be done in the community, but the constraint there is the staff and the expertise. So that's perhaps a more difficult topic to target. So future topics we have at the moment, we're going to look at community services and structures and how those work and how referral pathways work in the community. And we also have on our agenda to talk about sustainability, which is obviously close to everyone's hearts. And that's it. Any questions for me at all?
Anna, that was excellent. Thank you very much. Very eloquent, and I think it's so useful and so important that our discussions have those perspectives injected into them, and that we think it through. And you can see from the chat bar that you know, there's a lot of echo here in the sense that people are agreeing with you and applying it. I mean, clearly it's our objective as a health board to get much better at being clinically led, because that's all about providing better services ultimately for patients, isn't it? And listening to you and through you to the networks that you coordinate is such a vital component of that, that it's I think really useful, and very much looking forward to hearing these perspectives at every single meeting that we have in the future. It's really, really helpful. Paul, we'll come to you. You're on mute, Paul.
So I'm sitting here with a bit of a smile on my face now, because this is exactly why I thought it was really important that we established this group, because the sorts of points that Anna's made, and well, first the introductory points, I think absolutely, you know, chime with our ambitions for the organisation in terms of how we tackle some of those long-standing health inequalities issues. And we know that our population in this part of the world is particularly challenged in that regard. So I think, you know, it was a very helpful reminder as to why this is so important, and also why it's so important that we harness the collective knowledge base and of all of our clinical staff across the organisation on this, because as we've always said about population health, not only is it the clinicians to try and help guide the population into the right choices, but it's also we are exemplars in our own right, because we are all members of the communities and 13,000 people across the organisation who can influence that. So I think that's really important. But I also think, you know, Anna's perspective and those of her colleagues on the sounding board are really good reminders about some of the things that get in the way of clinicians doing the right things for patients. And I think this is also a really good opportunity for us to remind ourselves that, yes, there are big strategic conversations about population health that we need to tackle, and lots of strategy work will be going on now over the next few months. But there's also, from my interactions with the group and the sounding board, lots of very basic practical things that would make a massive difference for our clinicians and enable them to do things more quickly and more efficiently. So I think what would be really helpful as this group develops is being able to make sure that Anna and her colleagues have got the route into, you know, some of those other support services or other parts of our organisation, so that we can really show an evidence to clinicians that by being engaged in these sorts of forums, not only do you get the opportunity to influence the bigger strategic conversations, but you also hopefully are able to influence how we resolve some of the more fundamental day-to-day issues that people are dealing with. So I think it's a really fantastic start from the group already. It's exceeded my expectations of what they were going to be able to do in such a short space of time. But I also think, Marcus, it might be worth us thinking in the future about one of our development sessions, perhaps inviting the broader group of clinicians along from the advisory group to meet with the board and have a more developmental conversation about some of these things, particularly as we get into the strategy arena moving forward. But thanks a lot to Anna, because I think she's done a great job of stepping into a role that was not really defined very clearly where she started, and her first experience of getting into a leadership role in the health board. And I think she's doing a great job in terms of pulling it all together and leading that group forward. So thank you to her.
Thank you.
Thanks, Paul. And I just here say we all. Yeah, that's great. Anna, thank you. Time is pressing and we're going to have to move on with the rest of the agenda, but that was just really the beginning, I think, wasn't it, of the influence and the shift in orientation which that influence will hopefully lead to. So great, and thank you so much for that. That's really helpful, and look forward to you becoming a permanent fixture.
Thank you.
Thanks very much. Right, colleagues, we're going to move on, and I'm going to seek your help really in us moving on as briskly as it is sensible for us to do so, because time is against us and we still have quite a lot to cover. So item 6.1 is the population health update, and Angela, I think you're going to present that. Thanks very much.
Thank you, Chair, and thanks for the opportunity to present this as well. So I think it leads on very well from the conversation that we've just had, actually, because Anna very articulately said that we needed to tackle the dragon, and a lot of the data that's presented in this report just shows the shape and the ferociousness, if you like, of that dragon in terms of what our challenge is ahead. The approved last month some very clear goals for 5 years about improving life expectancy, healthy life expectancy, and tackling some of the inequalities that exist between the more affluent and most deprived in our communities, and particularly those people with mental health conditions and those people with long-term conditions as well. So there's a lot of goals that have been set. What this paper seeks to show really is some of the baseline, and it's quite a developmental paper because some of that data isn't available currently, so we need to do some more work with it, but some of that is set out in this paper, and I don't intend to go through the whole of it because I understand that members will have read the paper, but I'll just highlight some of the main issues, if I may. Firstly, I'll move on to COVID though, because it is important that we have an update on COVID, and the data that has been presented in the paper was the current situation a week ago. We always have this sort of 4-day time lag while all the data is verified, but we have seen a much improved position from this time last week. So our rates have reduced considerably across all of our local authority areas. We peaked on about the 14th to 19th of July, and we've had a consistent reduction in rates across our area since then, but we're not out of the woods yet. Our positivity rate has actually increased, so that's the proportion of those people who are tested who are actually positive, so we need to keep a really close eye on that. But you know, some of the reasons for the reductions will have been the schools closing and the large amount of children that were self-isolating, because it is in our younger groups that we still have the highest rates. Also, the Euros finishing has also helped, I think, in terms of really close contact among younger people. And of course the increase and the pace in vaccination in that age group as well, particularly 18s and overs. So just to give you a little bit of update there, we are still very, very closely monitoring our care homes. We're still getting cases in our care homes. I think we've had 24 care homes that we are closely monitoring. The vast majority of those have staff cases, but we have got 7 care homes where there are residents affected as well, and that includes both vaccinated and unvaccinated residents. So we are keeping a very close eye on those, and also the hospitalisations. And in terms of our vaccination progress is still good. We have a group that's looking at reducing those inequalities, because some of our groups of populations, some in different geographical areas or other groups in our communities, haven't had as good uptake as the more general population. And we're targeting those populations, working with those community groups currently, and that gap is starting to reduce again. So again, that is important that we keep that going. There's still lots more work to go. In terms of the update in the progress with population health, the board agreed 37 actions to take forward as individual projects, and that is a wide range of projects that both will impact on the interface between staff and our residents and our patients, but also for our staff well-being generally, and the use of our facilities, what types of food we serve and cater for. So there's a whole range of projects that have been initiated with that, and there's executive leads to take all of those forward, and there are consultants in public health who are supporting those. So we're currently scoping those projects ready to deliver. There's work ongoing with the population health management, which is seeking to look at all the data related to hospital use and diagnoses of our whole population, so that we can look at where we can best impact with different groups of the population and provide better services closer to home. So the data has just come in for phase 1 of that, and we're expecting phase 2 data coming up well, probably towards the end of the year now. So just to keep you updated on that as well. We're plugged in with consultant leads in each of the systems groups, taking our work forward across each of the population groups, and more broadly across the system with our partners through the needs assessments that are currently on way. So specific to some of the long-term conditions, we continue to do a pilot around identifying pre-diabetics and being able to provide the right support, as Anna said, to help support people to turn around that trajectory. It's not an inevitability that people will become diabetic, so catching the early signs and providing support is really important. One of our biggest challenges is obesity. We've heard today the great start that we've had in maternity services, and that's been developed over the last 5 years, and our ladies engaging with that very effectively. We need to expand our services. We've got very good services in relation to smoking and smoking cessation, but we're way behind on obesity as a nation, really. So we need to have the same level of services to support people for obesity, and there's work ongoing to develop those now. We want to get into a pattern of presenting data as it becomes available. Some of that is produced nationally and at a UK level. So we've just had the National Survey for Wales published, so we can see where we are in terms of percentage of adults who smoke. We're just above Wales at 18.6%. Wales is at 17.4%. And across our areas, we've got different smoking rates in each of the local authority areas, with Merthyr Tydfil having a slightly higher rate. But I think although we are still above Wales, we are closing the gap. So that's really important for us. If we look back 10 years ago, we had smoking rates in Merthyr of 32%. They're much, much lower now. So we are closing that gap with the continued work that's ongoing, but we've still got to maintain that momentum, because there's a huge challenge And you can see in terms of particularly diet, meeting physical activity and being of a healthy weight, those are areas where we really need to work hard to close that gap, because those are what contribute to people having long-term conditions and then having lower expectations about their life expectancy, and those come into fruition. So that's why we need our whole systems approach for that. So I won't go into all the detail, just to remind us that we do have a lower life expectancy for both males and females, males compared with Wales, and our challenge here and across our system is to close that gap within 5 years. So this is our baseline for moving forward. And most importantly, we have this really high, what we call a slope index of inequality, which is the difference between our most deprived, sort of healthy life expectancy and the most affluent. And we want to close that by at least 20% over the next 5 years as well, so that we can demonstrate that we are seriously tackling inequalities. So that's a big challenge for us going forward. I'll just move down now to infant mortality rates. Our goal is to be lower than 2 per 100,000. We're currently at 4, and similarly with low birth weight babies, and mostly because low birth weight babies, the impact of them having a low birth weight goes on throughout their life. So again, we want to reduce that to the Wales average. So it has been reducing gradually with some of the initiatives that we've heard, but we've still got further work to do. Our national screening programme data is presented as well. We are below where we should be with cervical screening, slightly higher with breast screening, slightly lower with abdominal aortic aneurysm. One thing I wanted to highlight was, although we're not reaching the bowel screening targets yet, we are now slightly higher than Wales, and a lot of work has been done with our GPs owning that and contacting patients and encouraging patients to take up that screening, and that has resulted in improvements in that rate. So just to say that there are initiatives that we can trial in some areas, then roll out, and they really do make a difference. And then finally, I've included at the bottom some smoking cessation activity, just to show that the momentum on that is continuing. It didn't drop down a lot during COVID because smoking was identified as one of the risk factors in terms of respiratory conditions. So we maintained really high levels of support, although it was all online, of course, or via telephone. And we're still improving on those where we were last year. So I'll stop there, Chair, as a quick overview.
Angela, brilliant. That's really helpful. And as you can see from the comments, enormous amount of support, and people making the very point that, you know, all of this just reminds us once again of the importance of doing what we've been saying all along this morning, of focusing on population health, as well as providing excellent care for people. Colleagues, are there any points anybody wants to make on this? Paul, I think you wanted to come in.
Yeah, just Marcus, to say, absolutely agree with all the points Angela made. The obesity point is obviously a really important one, and we had a session yesterday with the chief execs of the local authorities with Kelechi, and this topic came up, and we all agreed that basically, you know, this is a subject that we all collectively need to prioritise for the next 12 months, because as we all know, this isn't just the health board focusing on obesity. This has got to be everybody in every area of people's lives. So we're very clear. We were very clear yesterday with the local authorities, and I'm really encouraged that they were very much saying, well, what can we do to help, and how can we have a joined up strategy across health and local authorities on obesity as a priority area, focusing right down into children's education, because we know we've got a big problem with childhood obesity particularly, so it sets the scene. The other point to make was just that point about how do we affect the change, because as we all know, this isn't about just telling people what to do. We've got to find ways of doing that which encourages and supports people to make the right choices. And I was just referencing back to Mel, and I spent a day last week in Merthyr, and Mel took me around and introduced me to a few voluntary groups and community groups who are working with some of our most vulnerable communities. And the theme which very much came across from that was, well, actually, we've got a whole architecture out there of people who are doing a lot of work with our most vulnerable communities already, and we should be tapping into those groups and using them as a vehicle for getting these messages across, rather than necessarily being us or the local authority sort of being the sort of big statutory public sector organisations that go out there and tell people what to do. So I took away a real sort of opportunity there to sort of think about how we could broaden our network in voluntary and community groups, but also to not make assumptions, because we were talking to the lady who manages services for people with domestic violence, saying, we talk about, batch cooking food to try and encourage healthy eating. Well, if you're working with a lady who hasn't got enough money to put in the electricity meter or hasn't got a freezer, then it's slightly odd conversation to be having. So we also need to use those groups to understand a bit better some of the particular vulnerabilities in our communities and how that influences their ability to make the right choices. So I think a really great opportunity to use this now as a lever for really looking differently about how we engage with our communities particularly.
Brilliant, thanks very much, Paul. So, colleagues, Angela, you'll have sensed people's enthusiasm and interest in all this. This is really strong and a really important frame, really, for what we do as a health board. So thank you. We're asked colleagues to note it, which I'm sure we're very happy to do. Angela, thank you very much indeed. Let's move on. And we need to catch up the pace a little bit, colleagues, if we can. So Linda, you seem to be taking half the items for the rest of the agenda, so it's all down to you, Linda, really, and your time management skills. But no pressure.
I can do speeding up. If I go too fast and too high level, people will be able to come in with questions, won't they? So the first paper is about how we're approaching writing out or agreeing and developing our organisational strategy to deliver on exactly what the last two presentations have brought to our attention. I think we know that we don't actually have a Cwmtaf Morgannwg strategy because the pandemic arrived before we were able to get onto that boat. So this is the first time for this organisation to be able to articulate its priorities and its plan and how the clinical services should be developed to deliver on those population health outcome requirements. So we are looking at a process over the next 6 to 9 months, extremely inclusive of our own workforce and partners and people representing community bodies and individuals who come forward to do exactly that, to help us understand where our priority actions should be. We are asking the board to formally approve the simplified 4 strategic goals of creating health, improving care, sustaining our future and inspiring people. Some of those might need a bit more explaining, which is what we're going to do in the next phase. So we've engaged an external partner. This month we're doing all of the work behind the scenes to identify what workshops we need. We're setting up a steering group. People like Anna are on the steering group and a range of other clinicians. We're looking at the topics in the paper there for some workshops and starting to identify clinicians to invite and others to invite into those, and using the time in August to pull together some stats, a bit like we've had from Angela, some drivers for change, and to do a proper professional looking launch in September. So proper launch in September, probably some little videos that explain those strategic goals in a bit more detail, and then starting the workshops in the end of September. So that's it. Really, that's all I need to say on that, unless there's any comments or questions.
So thanks, Linda. That's great. And we've all had a chance to think about this on more than one occasion, haven't we? So hopefully this is all very familiar to people. So we are asked to approve the strategic goals and to note the progress that's being made. Colleagues, I take it we're happy to do that. I'm just looking in the chat bar to see if there's anybody wants to come in on any of that. No, I think I think that's very strongly supported, Linda. Thank you.
Thank you.
So let's move on to 7.1, and I think you're taking this one, Linda, as well, aren't you?
I am, in my colleague's absence, and I want to. I think this is the performance scorecard, and I do want to just bring our attention quite seriously to this, Chair, because this is less happy reading. We've had a lot of progress over the last couple of hours about where we are making good progress, and of course, as we're coming out of the pandemic response and trying to recover and trying to pick up on the targets. Oh, I'm sorry. Somebody's just printed something from another room and it's right next to me. I hope you can hear me. As we're trying to pick up now the normal targets that we're subject to, obviously we're starting from a deficit position, and you'll see from around 30 indicators on page 4 that we're actually only meeting 2 of those, and all of the ones that are subject to capacity in services are behind where we'd want them to be, and I think recovery is going to take some time. I think it's worth saying that the system's extremely under pressure at the moment. You know, that this morning we had ambulances waiting to offload into our EDs. So it's not, and there's been a lot of pressure on the emergency services across the last 3 or 4 weeks. And of course, as we all know, high numbers of emergency admissions has a knock-on effect on our ability to do everything else. If Gareth was here, he would tell you about the work that he's doing with the ILGs, the integrated locality groups, to through performance reviews and through planning and activities to try and increase our activities to recover these indicators. And I think we can see an elective recovery plan in the next document. So I think we're just going to have to watch this quite carefully, if I'm honest, in terms of the rate of progress. There are some things I did want to pull out, which I will do quite briefly. On page 6, we can see that although there's been a decline in serious incidents, that's partly to do with changes to the reporting regime, and there are some unexpected deaths that are being investigated, and a very close eye being kept on that area. We can see on page 7 that we have had was getting a bit behind with dealing with complaints, although people that have complained are at least getting an acknowledgement and an explanation around that delay. There is one area of good news. On page 8 we can see how a review of hospital falls has created a change to the staffing profile, and that has had a positive impact. I think that's worth noting that, you know, we are still working hard to make improvements. On page 9, though, we can also see that we've had an increase in pressure damage, and but the pressure scrutiny panels, you know, hopefully those will start to have the same impact as the full scrutiny, and that we will see areas for improvement. But I think really, you know, there are concerns around the fact that staff sickness, although long-term sickness has reduced, we're now seeing an increase in short-term sickness, which I think resonates with what we understand about how our staff are, you know, have been under extreme pressure, and, you know, there was a manifestation of perhaps of some exhaustion. So I don't need to labour the fact that we're behind really on our elective services, and our cancer wait times aren't where we want them to be either. But I think, as I say, the recovery plans aim to be clear about when we will recover in those areas. I think people would have read the report, but I just felt it was important to be honest and open about where we are in relation to those things.
Absolutely, Linda. Thank you very much. Paul, did you want to make a comment, and then I'll come to Patsy and to Nicola. You're on mute, Paul.
Sorry. Yes, just to reaffirm really what Linda's been saying, I think that the pressure in the system from the non-elective side is significant at the moment, and we have the sort of perfect storm at the moment of slightly increased COVID numbers in our hospitals, increasing non-elective demand coming through the front door, impact of COVID being felt in the communities, with social care colleagues particularly being impacted by the numbers of transmissions increasing, and self-isolation, etc. It really is creating a bit of a challenge. It's not unique to us. It's being felt across Wales and indeed the whole UK. But having said that, we are working hard on that. But it does bring the added challenge then of the elective work, trying to catch up the elective work against that backdrop, and against the time when staff are feeding across the organisation already exhausted from the past 18 months. And we are also wanting to encourage people to take their annual leave at the moment. So it does feel a particularly challenging time. And just to give the board assurance that Gareth and colleagues are very much focused on the elective work. They are trying to do what we can do. Gareth's on leave this week, but I know when he comes back next week, he'll be talking to Linda and other colleagues to take stock as to where we are given the current pressures. But I think it is, as Linda said, something we need to keep a watching eye on, and I think Gareth will probably be able to give us a further update when he's back from leave next week.
Thanks, Paul. Thank you. Patsy, we come to you.
Okay, I've got 3 questions, but firstly, I just want to say how pleased I am to see the Health Board is continuing to investigate the SIs, even though the Welsh Government reporting standard has changed. So you keeping the discipline and learning from those SIs that don't now need reported through Welsh Government, which is really good. 3 questions then, which I'm happy for somebody to come back to me at a later date. Firstly, on people, so for Howell at 2.1, I just wonder why it's so difficult to get leavers to take part in an exit interview. It appears that the target is 60% and the actual is 3%. So that's one question. Shall I go through all of the questions first, Marcus, and then?
Yes, if you would, Patsy. Yeah.
Okay, so that's one. At 2.4.3, the cancer waiting times. Linda, you probably won't be able to answer this immediately, but will we know at a future date what harm has been done by those increased waiting times? We all know cancer itself causes harm, but the increased waiting time may in itself cause harm, and that's what I'm particularly interested in there. And again, for something to come back later, on the dashboard itself, the ophthalmology waiting time doesn't seem to move. If anything, it gets slightly worse. Certainly doesn't improve, and I think we need a greater understanding of that and the actions being taken, and I have discussed it with Jane earlier to see if we can request a report comes into a future quality and safety. Too late for the next one, but maybe the one after that, some kind of deep dive, but mostly to understand the actions that are being taken to improve that situation. Thanks, Chair.
Thanks, Patsy. That's great. Let's just see then which of these questions it's sensible to answer now and which require a bit more work. Howell, can you talk to us about the
Yeah, sure. So that's a really good question, first of all. So I think there are 2 reasons. I'd be really candid about this, if I may. So one is around process. So we've designed a wonderful process that works for us, but doesn't actually work for the people who are filling in the surveys. So we need to do some work there. So as Nicola has noted, that there is a specific work stream of the employee experience work that we're doing that's looking at moving on work stream, which is looking at exactly that. So we plan to redesign that so that it's much more user friendly for people who we are asking to complete it rather than for us who are collecting the data. So that's the first thing. The second thing is it's just too late to ask people once they've left why they're leaving. So again, as part of our work, we're also exploring more regular if you're thinking of leaving us type interventions, and indeed then we will try and do two things. We'll still try and learn from those who've left who we may not have captured, but we also can attempt to resolve issues if there's a chance then that we might be able to retain people better. So that's a key part of our work, but I think it's twofold. It's around process and it's around that being too late in the process, really.
And how, let me put you on the spot, when are we going to hit 60%?
Marcus, I don't know. So we'll redesign the process as the first step, and then I think we're gonna have to see how that goes and play that by ear. I've all throughout my career, exit questionnaires have been challenging, but we'll give it our best shot.
Okay, thank you. Harm through cancer weights, is that something that can be answered now, Linda, or not?
So I think for both this one and the next one, Chair, just acknowledge these are really important questions, but I could only give a partial answer, which I don't think would be helpful. So we'll come back with a complete answer.
Super, that's very, very helpful. Grand. And I note Dom's comment in relation about ophthalmology as well. That's very helpful. Thanks, Patsy. Excellent questions. Nicola?
Thank you, Chair. And as Patsy, I'm quite happy if we have an answer outside of today's meeting, because I'm mindful that probably it is a long question. And I think if we pick up on Anna's point where she says we need to have a focus on our children to improve our future. And if we look at 3.14 of the papers on our consent agenda, it talks about embedding the children's rights. And under that approach, the terms of that require us to help children to reach their full potential. So I think I'm a little disappointed to see that the wait times for our ND team have increased by 30 more who are not meeting our target between May and June. It's a constantly rising figure. I can see from our risk register that, you know, under what we've put in place is to move the lead to general paediatricians. And I'm just wondering what difference moving into the general paediatricians is going to make. And when can we really expect to see some improvement? Because this is an area that just seems to be continually decreasing in its percentage of our compliance.
Thanks, Nick. Great. Julie, did you want to come back on that now, or do you want to come back on that after today?
Yeah, I can give an answer, a brief answer today, and follow up with an action. If that's okay, Nicola's absolutely right, and you know, the lives of people are on hold, aren't they, whilst waiting an assessment and often an ongoing intervention in this area. Actually, it is part of the planned care recovery programme. It's acknowledged that there's huge significant waiting times there, and only yesterday, I think it was, we met with a company, and it was our second meeting with them as part of looking at insourcing some extra capacity to help in this position. So what we can take away as an action on this is, again, for the action plan in terms of improvement around this from the planned care programme board to come through to quality and safety at a later date around that, so that there's some oversight around it, because it is an area of deteriorating position and concern around this. But to assure you, everyone's aware of it and trying to find some additional help, because there isn't the capacity internally. It's a very particular area of skills. So hopefully we can procure something that will help support that position quickly.
Sorry, Chair, can I just quickly come back to say thanks, Julie, because I know Bridgend were looking to use Halcyon as a support, but I wasn't getting the impression that was throughout the organisation and that there was consistent support.
Yeah.
Right. Thanks, Nicola, for raising that, and Julie, we look forward to seeing what can be done. Thank you very much. Linda, thank you. Really, I mean, this is the heart of our business, and as you say, not at all surprisingly, it's pretty grim, actually. I think in a lot of respects, not at all surprisingly, given what's been happening over the last 18 months in the world. But thank you very much. That's very helpful. Let's press on then. Annual plan. Again, people will have read the paper. Linda, anything else you need to say?
So, Chair, as you say, this has been presented previously at a board subcommittee. Actually, I can't now remember which one that was, because we had to submit on the 30th of June. So it was out with the cycle of board meetings. or PPF. Thank you, Callie, for helping with that. So most people will have seen this. It's the submission of the annual plan to Welsh Government, which responds to the feedback that we had from them after the March submission. So it does address questions of financial balance and the triangulation of activity, workforce and finance. We are simply presenting it here for public and formal adoption and approval.
Thanks, Linda. Paul.
Yeah, just to say I support the submission. We had a conversation on Chief Exec's meeting with Andrew Goodall on Tuesday this week. With I think there is further feedback going to come on the plans from Welsh Government, but it won't material. We need to formally approve this process now, and there'll be an ongoing dialogue with Welsh Government about further refinement around particular areas that they're picking up with individual health boards moving forward.
Super, thanks, Paul. And as Dilys has helpfully pointed out, that actually it wasn't just that committee. I think a number of people in addition attended, weren't they? So that was a good discussion there. Good, colleagues, are we happy to note that? I think, yeah, we are. Thank you. Good. Moving on then, Julie, I think you're going to talk to us about the elective care recovery portfolio.
Yes, thank you, Chair. I won't go through the paper in detail, conscious of time, but actually people have had time to read it. But the paper seeks to provide an update on overall progress that's been made following the agreement of some funding from Welsh Government in relation to elective and planned care. So the paper covers the establishment, I guess, of the programme of work around that, the governance of the planned care programme, and some early work to address needs of people waiting. And I think the things I want to say in framing some of this is that we know many of our population are now waiting for routine procedures, for elective or planned care procedures. For many, that's a wait of months. For many, that's a wait of years. But we don't actually know the absolute stop point in terms of what that will look like. All the evidence suggests it will continue to grow over the next 12 months as people with long-term conditions start to represent to services that they might have presented with ordinarily earlier on in the pandemic. So it's still an unknown quantifiable endpoint, I think, is around this, and clearly with a difficult and challenging winter ahead that's already started in our summer months around this. So I think the message is we probably don't know our endpoint yet and won't for a little bit of time. That's no different to anywhere else across the UK and probably the world is the reality, but not a pretty picture that we're describing. I think what we've got to recognise is failing to make headway on the backlog will continue to increase the system pressures, because all that happens is people will continue to present elsewhere, won't they, whilst waiting for interventions that we know they need. And they will present in primary care, they will present in our ED departments. And I think that's some of what we're probably seeing now in some of the system pressures. When people are waiting, we know they're in pain, we know they have difficulties, don't we? So for our population, making headway into this is really important. And I think one of the things we've got to think about within this programme of work that we've probably not yet quite captured is how we capture the context and of our voice of our population for our people waiting in terms of their experience and how they would like us to take some of this forward as well. What I can say that's in the paper is the challenge we're taking is that this is an opportunity as well. If we only look at traditional waiting list initiatives and don't address this from a multifaceted approach, then I think we're going to be still sat here in 5 years' time with a backlog of people waiting. So I think the challenge in all of this is to embrace technology, embrace different methods of working and embrace different solutions for some of our population who might have been waiting for an elective procedure in the past. So what you'll see in the paper is there's work going on in clinical validation. Pre-validation, we're looking at some options around that. Clearly working up our approaches to see on symptoms and patient-initiated follow-ups, and we're doing some tests in a couple of areas around that to see what unintended consequences there might be from those approaches as well. We're looking at more traditional methods of insourcing and outsourcing for a range of areas, and I note ophthalmology conversation earlier. That's one of the areas where we've got some work going on. Clearly, as part of all of this, we need capacity in testing as well. So it's not just interventions, it's the working up and understanding of what procedures people need. So, you know, we've progressed regional and mobile units to support additional capacity in the space of testing so we can keep that flow coming through to diagnosis. Some of the work we're doing that's a little bit more different are looking at wellbeing hubs, and one of our clinical leads are progressing some work on pathways for wellbeing hubs, because actually while people are waiting, the more we can do to increase their wellbeing, and going back to the population health paper, the more we might not need the interventions in the first place that we thought we needed. So tackling it from all ends is really important. We're doing some work around irritable bowel syndrome to see if we can change the approach that people might need at the end of that intervention. Same for pain management, because there's good evidence bases in cardiology. Also increasing access through the Plan Care programme for urgent dental care as well, because we know there are still bottlenecks in that because of the approach. So that's what I wanted to cover, I guess, really, other than to say there's now an established weekly oversight meetings that will transition to a monthly board over the next month for some clear oversight. I think some of the issues that Linda picked up and the questions then that Nicola and Patsy raised in relation to performance. I think what I will propose to Gareth as part of handing back is that we have a regular paper in relation to some of the issues in the planned care board to quality and safety. So some of the themes in terms of impact on our population are picked up through quality and safety there, as well as through performance meetings for the more detail in terms of how long people are waiting. Thank you, Chair.
Thanks, Jane. I think that would be a very helpful suggestion. Thank you. Colleagues, any questions or comments? Jane.
Thank you, Chair. Thank you, Julie. Thank you for the suggestion. I welcome a regular report to quality and safety. And I think that will address one of the two risks that's identified in the paper, which is the potential effect on our population of the waiting list delays. There's another risk identified at 3.1 in the cover paper regarding support from informatics and performance, and in bold, at pace is now required. Does that indicate that we think that we're not going to get that support, or there's a risk that we don't actually have the ability to provide the information for us to understand what needs to be done?
Okay, I'll pick up that question, recognising others want to come in as well. I think it's about the general volume of asks we're making of our informatics department across the piece with all the planned care, all the system pressures at this point in time. Should there be a problem securing that, we can feature that in the quality and safety paper, but we're certainly, the board have already invested during the pandemic in increasing capacity in ICT and informatics as part of recognition that we've all got asks of them.
Thank you.
I'll just come in on that, Mark, as well. I think Julie's absolutely right. We have put some more capacity in. I think, to be fair to our colleagues in that team, we are constantly, as Julie said, making more and more demands on them as we get to try and get more underneath what's going on. We want to get more operational detail. We want to get more data. We ask our information performance team to produce some more information. So I think it is an area where we need to be doing some further work on. We're just about to kick off the strategy work. That will require a whole load of information as well. So I think it's an area where we are going to need to get some thoughts together about moving forward into next year, what additional resource we might want to be putting into that team to meet the competing demands that are out there at the moment.
Thank you, Paul. That sounds sensible.
Super. Thank you very much. Colleagues, then we're asked to note the report, which I'm sure we're happy to do, and we'll continue to watch this with close interest because it is so important and so huge. Thanks very much, Julie. 7.4, Operational Resilience Winter Planning. Linda, back to you.
Sorry, let's take a moment to come back online. This is to just inform the board that given the pressures that we talked about earlier, in combination with the risk of an increase in COVID cases, alongside a risk of increase in RSV cases and potentially flu. I think Don will say that, as people start to circulate, I think you said earlier, we're all being exposed to viruses that we haven't, now got natural immunity to. We have stepped up our instant response, so we're now running a gold command once a week with silvers twice a week at ILG level, partly for surveillance, but also for fast response and appropriate actions. Obviously, there's a chance, as Angela said earlier, that the COVID threat is mitigated. You know, obviously, if anything starts to look a bit rosier, we can step it down. But our learning from last year was to get on the front foot, to have our systems up and running, and to be able to make decisions quickly. So this is just informing the board that that's the situation we're in.
Linda, thank you. And Dom is going to explain to us what RSV is, I think.
So RSV stands for respiratory syncytial virus. It's a specific virus that's out there that mainly targets the whole population, but the effects really are in the young 0 to 1, but even up to 6 years old patients. It's a very thick mucosal that blocks airways. So it's a significant problem for the younger child who can't actually clear and cough their own airway through. They deteriorate and sometimes need humidified air, and in other situations they need to be intubated and ventilated. That's around about 4% of children who get it end up in hospital needing care. The GPs and community services have a huge impact at every year. It comes every year, we know about it, we expect a peak every year. This year is obviously much worse because 0 to 2 year olds haven't been exposed to it because they haven't been out and developed it over that period of time. So we're getting almost 2 years worth in one peak. That's what the problem is. Flu is very different again. Then there's paraflu, and there are sort of 15 different viral illnesses which we are expecting to come up to the fore over the next few months. So it's not so much COVID, I think, that's going to be causing major problems in the next few weeks. It's going to be the viruses because of the COVID isolation that has caused this peak to occur. So we're monitoring all of the different illnesses, but as I say, that the impact has already been felt very strongly, both in secondary care, but even more so in primary care, where they're trying to deal with a lot of parents who obviously haven't seen any of these illnesses before and are understandably very nervous and worried about it. So it's a big impact on us already. Sorry, that was a long explanation.
But no, very helpful, Dom. Thank you. Any other colleagues, any comments or questions on this paper on operational resilience and winter planning?
Should I just answer that question on flu vaccination, Chair? Just to say that the flu vax planning is in full swing and will build on all the successes of previous campaigns. I know that will be starting early in the autumn.
Right, thanks, Linda. In which case, colleagues were asked to note the paper, and I'm sure we're very happy to do that. Linda, thank you very much. 7.5 Organisational Risk Register, Callie.
Thank you, Chair. Just very briefly, just to present the latest situation of the Organisational Risk Register that was signed off at the June Management Board, and since we've realigned our committees and board meetings, it has obviously now been received at committees prior to coming to board, which I know was an ask of independent members. Just a couple of key updates. The integrated locality groups are still on track to do the RIDE review they were doing in respect of our internal audit findings on their risks, and that they have a deadline of October for that, so we're on track for that. Within the update, I won't read them all out, but we've obviously noted any changes this time in red into the Organisational Risk Register, and we've obviously included in section 3 any updates to new, closed or risks that have changed this period. One of the things I want to pull out on is that what is really going well at the moment is around our sort of improving our risk culture. The monthly training sessions that we've commenced since January have been proven hugely popular. We're probably getting about 40 people through a month, and just this month in July we've seen about 40 people through the sessions, and that also includes a dedicated session that I've done with primary care colleagues and also with our programme management office about linking in programme risks and organisational risk register, making sure we've got those linkages. So the training is proving really popular, and I think that is helping then to roll out our improved risk culture that has been an aim of the programme since I've been in the last 12 months. I do want to draw attention to the comment in the cover paper at 3.4, where we've noticed a change to Datex ID risk 4149 relating to our CAM service. I just want to assure the board that this risk has been updated since this report, and it was signed off at July Management Board and will start now to go through our committee structures and then received at the next board. But if I may, Chair, I'd like to bring Julie Denley in just to provide a quick update on the escalation status of Teilyard, if that's okay. Thank you.
Yeah, thanks, Callie. So a number on the meeting today met with Welsh Government on the 12th of July, or WISC colleagues in effect, on behalf of Welsh Government. So having recently been escalated CAMS from level 3 to level 4, we agreed to meet in order that we could develop a joint action plan to work towards de-escalation of Teilyard, because I think it's really important to understand what good looks like and how do we reduce that position. The reason CAMS was escalated from a level 3 to a level 4 were on two issues, both known and both declared by us as a health board. So it was no surprise to us, and we were in agreement with the change of escalation status. First was culture and leadership. As we know, we don't fix that overnight. There's a whole programme of work in there ongoing related to that that's started to see some positive results. And the second one was related to a recommendation in a report a number of years ago in relation to the medical emergency response to Teilyard. A solution was found at the time. The Bridgend Integrated Locality Group team reviewed that and felt it could be further strengthened, partly because you have children and young people there under 16 and you have children and young people there over 16, and the pathway response is slightly different for those. So all the work has been done to review that, and we're due to close down that action with WISC on the second week of August, when the final processes have been put in place within the health board area. So not great news to say we've gone from level 3 to level 4 in terms of escalation, but to reassure there were known issues in CAMS that we were open with WISC about and declared ourselves in terms of that spirit of transparency, and we accepted that escalation. And I think the meeting was a very positive meeting with WISC and colleagues around this, and the next step we've got to do now is working on the maturity matrix that we've seen earlier used within maternity services and that the board developed last year, adapting that in relation to CAMS to help us frame what does de-escalation look like, what do we need to achieve de-escalation around this. So that's all I wanted to cover today. Thank you.
Right, thanks, Julie. Callie, anything else you wanted to say, or is that no, good?
No, that's it. Thank you, Chair.
Thank you, Patsy.
Two quick questions, Callie. The fire safety, it seems a strange time to be reducing the risk on fire safety, given the potential for a limited assurance internal audit report, given the HIW comment on finding problems with fire safety. And in the same report, fire safety risks have been enhanced in POW, and I get that risk 4392 is site-specific fire documentation, but the plans to improve that are plans and people being recruited. That hasn't actually happened yet. So as we sit here today, that risk is still very much a risk. So I'm surprised that the suggestion here is that it's being reduced. That's one question, if you have a moment to think about that. And the other one is Dom, really, I think. With controlled drugs, I notice on the report that there's a plan to increase the swipe card access for controlled drugs to 24 hours. If it's not 24 hours at the moment, how on earth do out of hours clinicians access the controlled drugs in an audited way?
So the way it is run, it depends on, it varies between the different sites as to what happens in each place. If it's on intensive care, for example, then it will be the named nurse in charge who will have access to it, and then it is counter-written into the notes that has been signed by that nurse in charge and the nurse requesting to be giving it. So there'll be a paper trail for those that aren't on an electronic audit on it. as far as I'm aware, I've got, honestly, I'd have to look into more depth with you to find out exactly where the other areas are. That's just one example I know off the top of my head. I know that the 24 hours is ambitious, but it's something we should have in place as soon as possible. Again, I don't want to make excuses for things. There was that pandemic which seems to have slowed things down. The progress in all that matters here. It expedited an intensive care, but it slowed it down in other areas. It is something we are looking at urgently and taking concern of. Let me get back to you, get a bit more detail and get back to you outside of this meeting, if that's all right, Patsy, if you're happy with that.
Thanks.
And Callie, fire.
Thank you, Chair. If I could just come in, and Howard also may wish to come in, because I understand that sits on his portfolio. But I think the reason, and I will go back to our fire safety colleagues, but I think the reason they de-escalated is they have been successful and interviewed and appointed. They're just going through that process. So I think they were reducing it on that basis. But if I can, Patsy, I'll take it offline, go back to them and just run that back through with them, if that's okay.
How would you want to come in?
Yes, and thank you, Callie, and thank you, Marcus. So I think at the same time as that, I'll just take into consideration the broader points that Patsy's made there when we're reviewing that risk. So we'll do that between us, if that's okay, Marcus.
Super, thank you. Thanks, Patsy. That's very helpful. Anything else, colleagues, that you want to raise in relation to the organisational risk register? I can't see anything else in the chat bar. So we're asked to approve the recommendations in relation to new risks, de-escalated risk, etc., and note the progress. And I'm checking now, but I'm sure that we're happy to do that, Callie, subject obviously to the points that Patsy has raised. Thank you very much. Let's move on then. 8.1, the Steve Webster Swan Song, as this is also known written in my notes here. Steve, over to you.
Yes, doesn't mean it'll be long, Marcus, so don't worry. Yeah, I mean, key points then, you know, we are break even, as the report says, small surplus of 22k. So what I'm just going to focus on, as I always do, is sort of what's under the surface of that. So firstly, just to stress that this is we're break even against our revised plan. The plan we sent at the end of June is not our original plan for obvious reasons. So that plan that we've submitted makes a number of assumptions about Welsh Government income, which is in line with the Welsh Government guidance, but is not signed off by them yet. So the first sort of qualification, if you like, or thing to note, is at the moment it is making assumptions on income which we don't know for sure we will get, albeit they're reasonable assumptions. So that's mainly from Welsh Government, and the detailed aspects of that are in the report, but also to a lesser extent from income from powers for the flows we are seeing into PCH. So first thing, it is reliant on that funding being achieved. Second point to note is that the savings plans profiled in over the period of this report, i.e. April, May, June, are relatively low, which has always been part of our plan, and they step up over the remaining 9 months. So not having a shortfall against that savings plan for the first quarter doesn't give us assurance, if you like, that we're on track for the plan as a whole, given it ramps up. So we have got plans that we will achieve. We're about 0.9 million off the in-year target, but those need to be, we need more assurance around those plans, and clearly there's some way to go. So I'm not saying this is a big risk, but there is a way to go on savings. And the second point, I think, just to flag about savings is while we're 0.9 million off on the in-year target, we're about 7 million off on the recurrent target. And I think as we go through the year, there will, as with all years, but I think this one, you know, in many ways more so, we need to have equal focus or more focus on the recurrent position as we go into next year. And that is particularly because whilst the plan is break even in year, this is if we achieve the plan and, you know, achieve all the aspects of the plan, then it's still got a recurrent deficit going into next year. And we know next year is going to be quite challenging in relation to the sort of economic situation. You know, public sector budgets needing to make a contribution to recovery post-COVID, you have the public finances, etc. We don't know the detail of that, but we know it's not necessarily going to be easy. So that third point is around the recurrent position. So the action, the paper sets out the actions we need. I think the sequence of that, and board members may want to sort of just like clock this and follow it up, and particularly at PPFC, is I think the short-term action is to get confident on the income numbers, both the Powys Fund and the Welsh Government. We've got plan review meetings with Welsh Government in mid-August, so I'm hoping, not that meeting, but after that meeting we will get some clarity. So I think that's the first thing to sort of get nailed, if you like, the security of those income assumptions. I think the second one is then the in-year savings, and the forecast at the moment is only 0.9 million off, but we need to get more confidence about it. And those two things together hopefully will give us confidence that we have got a realistic break-even forecast. We're forecasting break-even, but to get more solidity behind that, if you like. So that's the first objective, and I think we ought to be in that position sort of before the end of month 6, before we get seriously into the autumn. Let's say September, we ought to be in that position where we can be more confidently projecting forecasting break-even. I think that should be feasible. If we can get to that, which we should be able to, I think then there needs to be a lot of focus then on the recurrent position, and that will then lead into next year's planning, and it's relevant to the strategy work as well as the sort of more transactional savings and so forth. So I think that's the sort of sequencing, if you like, of getting ourselves firstly more confident about the in-year position, not that we're not confident now, but more confident, and then moving on to the real another dragon, which is the sort of recurrent financial position, but obviously in the context of all the other challenges that the health board's got. So I'll just pause there, Marcus. I think those are the key points.
Thanks, Steve. That's exceptionally clear as always. Patsy.
Yeah, you focused on the things that I was going to ask you about, Steve. Just one question though that I'm not sure was covered. Am I right in thinking the ILGs have only just recently finished their bottom-up savings plans? And if that's the case, 900,000 out on the in-year savings plan isn't such a bad place relative to the overall position.
Yeah, I think with all of this, we've just got to keep in mind, and we know this, don't we, that we started properly planning in mid-February. We would normally start properly planning in October or something like that. So we've started late for all the reasons we know. In terms of where the ILGs are now, then they are short of the target. It's quite variable by ILG. Some ILGs are doing better than others. And I think I would take your sort of view there, Patsy, that with more time to focus on it, more clinical engagement, more management engagement, then that should be able to move on. That's what we need to happen, if you like, to then move on to the recurrent position. So I'm not flagging a lot of alarm about the current year. I just think we need to get it. We need to get more confident about it to then move on to the real challenge, which is the recurrent position.
Thanks, Steve.
Thanks, Patsy. Any other comments or questions from colleagues on this item? In which case, Steve, we're asked to note it. Steve, thank you very much. As always from you, there's exceptional clarity, including that strategic perception and judgment that I've learned over the last 4 years can be relied upon, which is a huge reassurance in the finance director. And also, I think one of the benefits of teams is that we don't have to be in the same room as you and a full glass of water, Steve, which I remember on more than one occasion, it was always a sort of moment of anxiety whenever you and a glass of water came into contact, because it often sprayed over other people.
Yeah, normally no one was keen to sit next to me.
But thanks, Steve. Thank you very much indeed. As I said before, thank you for everything that you've done, and very, very grateful. Colleagues, we reach then item 9 on the agenda, which is any other business. I'm not aware of any. Is there anything anybody needs to raise? No, I don't think there is anything. Date and time of next meeting, then the next formal public meeting is held on the 30th of September at 10 o'clock. And that may well be a meeting in person, but details to be finalised. Colleagues, also just to remind you that we are holding a briefing committee meeting in a few minutes. We'll have a very quick break, and then we'll come back together for that meeting, which hopefully will be relatively short. So ring dod a cyfarfod o bwrdd iechyd I ben, hoffwn diolch bawb. Thank you very much, everybody, for the meeting. I bring it to a close. Thank you all very much, and colleagues, if we could come together again at 25 to for the in-committee session. Thank you very much indeed.